Well, hey everybody, welcome, and it's great to be back. So we're doing our second Fireside chat, and it's always great to have Dr. Valdis here. She's our Medical Director of Education. Thanks for being here and spending time answering some of these questions, like these deeper questions, as we roll through these new medical directives, and then helping provide some clarity and insight into those updates, Lauren, into the ALS PCS version 5.4.
My pleasure, Dwayne. And thanks so much for everyone here for joining us for our second Fireside chat. We had some great feedback based on our first Fireside chat. So we brought the fireplace back again to talk over some of the nuances and the practice changes that are coming up. So similar to our first Fireside chat, the idea kind of came from the fact that we teach during MCME your material, and then we say, hold on, don't use it until it becomes live. And it can be a long time until it comes to be live.
Yeah.
So there are some services that we actually taught this year in the spring, and it's not until the following spring, February 1st, 2025, that the changes are coming out. So we thought we would highlight some of the changes, especially the big ones, the take-home pearls, just to help jog your memories before these come out live into practice in our nice little cozy space.
That's right. And last time we did this, we were masked up. It was in the middle of COVID. It was absolutely horrible. You couldn't move anywhere. You couldn't sit close together, but now it's a better environment, and it's just good to sit down and go over these changes that have taken place, Lauren.
That's right. It's just so nice to be back in our, quote unquote, normal lives, both at work and as well at home. So Dwayne, starting from the top there, can you highlight a little bit about what we're going to be touching today on our Fireside chat?
Yeah, so basically there was a lot of things that happened during the MCME so far, and it's good. There were a lot of changes that took place. So we're going to be going over the cardiac arrest memos that came out about a year ago, because there is a little bit of confusion on what to do, like when can we leave early, what happens if the person goes into cardiac arrest well en route to the hospital. So we're going to kind of address those two memos and kind of clear up any misnomers with that. Mm-hmm. And then we're going to go kind of through piece by piece. We'll talk about the TXA, the pelvic binder. There's a big discussion about that, and we'll get into that and the reasons why and the context, as well as the supraglottic airway suctioning port. Now we're going to be using that little suction port with the catheter, clearing that out, as well as we'll talk about it's always an interesting topic, the Suboxone. So we'll get into that, and then we'll because sometimes there's just so much coming down the pipe. It can be overwhelming. And again, like the other topic we'll be talking about is more of a review, and it's just about the treat and discharge criteria for SVT and how to kind of roll through that. And it's good to know why these things have happened, why they're changing, what the medicine is, what the science is behind it. So that way we have that context, and it makes a little more sense as we roll into our ALS PCS version 5.4.
Yes, and we hope that you enjoy our cozy little chat. Dwayne, can you take us through what we have here?
Oh yeah, so we have some pumpkin spice cinnamon rolls we may have here, and we also have some homemade cookies with some M&Ms or Smarties in them. Yeah, and then we have some strawberry lemonade, and yeah, so we're good to go. Why not have the food of the season, and it's nice and comforting, and this will help everybody just kind of get into this and make it decent, right? There's a lot of information, so we'll go over that.
All right, Dwayne, let's jump right in and review the information that are covered in those two memos. Okay. They're all regarding updates to the medical cardiac arrest medical directive.
Yep.
And they're not new for ALS PCS 5.4, so it's information that you're actually using now in your current practice. And the memos you would have found in your inbox that came in June and July of 2023. So without further ado, Dwayne, can you tell us about the first memo?
So yeah, the first one we'll talk about, guys, is the when the person dies for the first time en route. Okay, we witnessed that. Now, that memo came out, like Lauren said, in June of 2023. And there were some notes in there, and if you actually go on the website, the SWORBHP website, under communication/forms, those memos are there. Now, this came out again in 2023. I'm just going to read verbatim what it says, because I think that's the best thing to do. Mm-hmm. So this is what it says. For a witnessed arrest in the back of the ambulance, paramedics should use clinical judgment to decide whether to stay and perform resuscitation or proceed to the hospital. Paramedics should perform either 3 full analysis and then proceed/patch, or to provide 1 analysis and go. The paramedic should provide at minimum 1 analysis. And factors that are part of that decision, including the distance to the hospital, the cause of the arrest, the ability to provide adequate CPR and ventilations, shockable versus non-shockable.
All right. And then just to recap there, Dwayne, this is for a witnessed arrest, not a rearrest, correct?
That's right. So the patient dies for the very first time. Now, the companion document out there already had some direction written in there that talks about what to do in the setting if they're in cardiac arrest. Then we have a ROSC. Now there's a rearrest.
And Dwayne, prior to the companion document being released in late March 2023, with the actual iteration of that ALS PCS coming out February 1st of that year, so about like a month and almost 2 months ahead of time, what had the direction been from SWORBHP? Because we taught that information about the ALS PCS coming out in the fall prior to it coming out.
Yeah. So what we had said was if they die for the very first time, pull the truck over when it's safe to do so, and then run the entire 20 minutes of the resus on the side of the road, unless there was reasons we had to get out of there. And it was basically surrounding crew safety, patient safety. Now, within that memo from June of 2023, we also highlighted there were some discrepancies in there versus the previous instruction versus what's going on now that we talked about during that 2022 fall MCME when everything changed with the cardiac arrest directives.
That's right. So we tried to be as transparent as possible, as we know it would cause some confusion. You were taught one thing back in the fall, and then more information came out in the spring changing that. And unfortunately, that's just the nature of the beast when it comes to getting ahead of these medical directives. We're going to touch a little bit about more on that later. But we really wanted to be clear with you that, yes, you were taught one thing. Direction has now changed. This is what we're going to follow. And that's part of the reason we wanted to be just as clear with that confusion on the memo as possible. Now, how should a paramedic treat a patient who arrests for the first time en route to hospital? Can you give us a summary? Because I know we just talked about a whole bunch of stuff there. So let's give if you can.
Yeah, like a Coles Notes type thing.
Would love it.
So basically, the memo states if they die for the first time, there's 3 options. So the option 1, they die for the first time, pull the truck over when it's safe to do so. If it takes time, just let us know. It took time to pull over, that's fine. Analyze the rhythm, like confirm their VSA, analyze the rhythm. If it's non-shockable, resume transport, keep resuscitating, don't need to bother pulling over anymore. The second option is they die for the first time, you pull over, confirm they're in cardiac arrest, do your rhythm analysis. If it's shockable, deliver the shock and commit to 2 more analyses. So what that does, that kind of keeps the information linear, because when you're on scene and they're shockable, we put 3 shocks in, then we transport. It's the same with this. So if you shock the first time, commit to 2 more analysis on the side of the road. Even if they're non-shockable, that's fine. We're going to be auditing it, we'll see it. The third option is patient dies for the first time, pull the truck over, confirm they're in cardiac arrest. If it's non-shockable, do your pulse check, non-shockable, 2 minutes of CPR, do your next analysis. If it's non-shockable, confirm with a pulse check. There's nothing there. Do 2 more minutes of CPR. Then you can do a third analysis. If it's non-shockable, you can get on the phone and patch to the base hospital doc. And if it's Lauren, it would be, hey, Dr. Valdis, I'm on the side of the road with a cardiac arrest patient. I've had 3 consecutive non-shockable rhythms, whether asystole or PEA. I feel no pulse. Can I stay on the side of the road and keep doing this for another 14, 15 minutes? The likelihood of that happening is incredibly low. So the reality of the job, let's come into reality here, people, is that if it's non-shockable, 1 analysis, keep trucking, get moving to the hospital, keep resuscitating. Or if it is shockable, deliver that shock, commit to 2 more. That way we're all on the same page. Even if it's non-shockable, that way we know, okay, because they could be in a refractory VFib state at this time. So
that's awesome, Dwayne. Thank you very much. That is nice and clear now.
Okay.
Not to muddy the water.
No, it's okay.
But just to go back to what we introduced a little bit earlier, what about a patient who rearrests?
Okay. So the way it's all written in the companion document, it's been like this for a long time, is that, say you get that person and they're VSA and you get them back and then they lose a pulse again, they get one more analysis, one more basically kick at the can, so to speak, one more attempt, shockable or not, deliver the shock, or if it's non-shockable, keep transporting. And that can happen. This may happen while you're trying to get out of the house, like, or the residence, wherever you're at. You may be working the patient, you get a pulse back, you think, okay, great, they're onto the stretcher, whatever the case may be, or on the stair chair or lifting chair, and then they go into cardiac arrest again. Do that next analysis quickly, and then basically you're kind of done, and you can just transport to the hospital, right? And it's either shock or no shock, but that's the re-arrest.
All right. Well, thanks, Dwayne. I think that really helps make it crystal clear. If you're re-arrest, you get one more kick at the can, like you said, and then you just continue on without any further stops.
Yeah.
If you arrest for the first time, you get a minimum of 1 analysis, up to 3 analyses. Yep. If you want to stay for longer than those 3, then you patch to the BHP. Exactly,
right? And I think the key is that when we're thinking about how we're going to do this, like shockable versus... it's going to be interesting because every situation is going to be a little bit different. But again, that's a good summary, right? Minimum 1 analysis if it's non-shockable. If it's shockable, get 3 in there. And but in the very rare case, which I don't think a lot of medics will probably do, including myself, is that if it's non-shockable, I'm probably not going to stick around. I guess it depends on different factors, but the likelihood is we're going to be leaving quickly, right?
Wonderful.
Yeah.
And then for the audience, we'll make sure that this information is highlighted in the show notes for you, just to highlight, sort of relay any confusion. Mm-hmm. You can find the information on the memos, of course, in your inbox, as well as on the SWORBHP website, as well as it's in the app as well. So under the medical references section, when it talks about, say, the APGAR or 12 lead 15 or modified, placement, it's in there. Yeah. So the memos are in there.
Yeah, so that's great, right? And these things can get dynamic, and it does, these things happen. And again, there's access to this stuff, and it's hard when you're in the middle of the call to pull out your phone and try to do this. And we're not asking it's going to be perfect, no, but we do the best we can. That's why there's 2 of us, and we say, hey, what are we supposed to do? There's nothing wrong with that. So, and these things, like Lauren said, it's an ever evolving thing with this. So it's a little bit different. So,
well, I think we've covered the first of the memos for the Cardiac Medical Arrest Directive. The second memo came out in July of 2023 and talked about direction for non-TOR patients. So, Dwayne, why don't we talk about what was covered in this memo?
Okay, so this memo, the second one, also pertains to the medical cardiac arrest medical directive, but specifically it gives consideration to patients who don't meet that medical TOR, the conditions for that. So,
and Dwayne, can you give us a quick example of what that patient might look like?
Yeah, so you may have that patient, you get there, they're in cardiac arrest, say they're initially PEA, then the next analysis they're now in VFib or fine VFib, so we shock them. Then maybe they go back into PEA or they transition into asystole. So that patient doesn't meet the criteria for the medical termination of resuscitation.
Gotcha. In essence, this memo was created to allow for leaving scene earlier than 20 minutes of resuscitation for patients who you are going to transport anyhow. Right.
Now, Can you reiterate why the whole 20-minute thing for everybody out there? Because that was a whole discussion.
Yes, of course. So we'll take a little bit of a history lesson going back there. So moving back to our first Fireside chat where we talked about the update of the medical cardiac arrest medical directive. Mm-hmm. And within there, for the first time, the condition of the medical TOR was no ROSC after 20 minutes of resuscitation. So that came from some studies that looked at patients in cardiac arrest and found that if a patient did not have a ROSC within 20 minutes of resuscitation and fit all of the other medical TOR criteria, that there was a 0.2% chance of survival. Therefore, patients that otherwise meet the TOR criteria and have been resuscitated for 20 minutes, that helps prognosticate, do we think that it's futile or not. However, if you have a patient that you're not calling for futility or for that patch for the tour, then you don't have to wait the 20 minutes on scene. So that's where this memo came from, to sort of place that 20 minutes, saying that you don't have to stay for 20 minutes on a patient who you know you're not calling for a tour for.
Right. So that actually helps us with kind of the timing of when to get off scene.
Exactly. And maybe, Dwayne, you can take us through the memo?
Yeah. So the memo, this was the number 2. This was the second one that came out, and it's fine. So there's a lot of little points there. So we'll talk about primary care folks out there and then advanced care. So essentially, there's 6 different situations for PCP folks and then 5 for ACP folks. So when we can leave early, when all hands are on deck. So resuscitation is rolling. I'll explain that in a bit. So, it speaks to the actual memo, says younger patient. Now, it does not delineate they have to be less than 16. It doesn't say that. I mean, quite frankly, if I pick any one of yous up, I'm older than you. If I'm ready to go, I'm probably going to get going. And I think that's okay, because if I got everything going, I'm ready to go. The next thing is that they talk about distance to the hospital. Now, it doesn't specify, I can see the hospital, or I've got like a 20-minute ride. I got a 20-minute transport time, or 30 minutes by the time I get out of the house. That's fine. Specifically for primary care, if there's no ACP backup. So basically, in a nutshell, there ain't no epinephrine coming to help you. Okay, so that's, if you don't have that, and when you're ready to go, you can go. If we've actually witnessed the person dying in front of us, again, we've seen them die, so we want to work that. They're not tourable. So when you're ready to go, we can all kind of get moving. The next piece involves the non-agonal PEA, and the kind of example is around 60, like the numerical value on the monitor with no pulse, obviously, and then an end tidal that accompany that, say around 30, because we may have pulmonary circulation, it's just not getting up yet, and maybe there's something going on, especially if it's narrow, so you want to get ready to go. And then the last one on there, and it's quite a mouthful, because it talks about the ability to perform high quality chest compression. I'm reading this verbatim. And resuscitative care during extrication and transport. This may include on-scene and extrication/transport resources, such as additional paramedic crews, firefighters, mechanical CPR devices, etc. All hands on deck. That's the easiest way to remember it. So we've got people on the chest. Somebody's running the defib. We got the airway taken care of. If it's an ACP group, we have our lines in, our drugs are going. The stretcher's opened up. The sheet's opened up on the stretcher. The belts are kicked underneath so we don't accidentally wipe out. The coffee table's moved out of the way. We have the door cribbed open. And if the door doesn't crib open, we grab a shoe off the shoe mat, wedge it in there, because we know the shock never works on these doors, and crib the door open. Everybody's ready to lift. Back doors of the ambulance are open. Let's get moving. That's all hands on deck. When you're ready to go, you're ready to go. Now, Lauren, that memo does state for analysis. Now, how I interpret that, and I think this is the consensus among medical counsel, is that you don't have to have 4, but the likelihood you'll probably have 4 in before everything's ready to go type thing. Mm-hmm. Is that what they're kind of getting at there?
Yeah, and the wording of the memo says, from a timing perspective, that you should really perform, a minimum of 4 analyses before going. Not because, 4 means anything other than, just like you said, that you've gotten everything ready to go, that you've optimized things before you get moving. What we don't want is that load and go from the perspective of nothing happens with the load and go. We want good quality resuscitation to be ongoing. Right. And that's where that really wordy sort of point comes from, is that the patients that are going to do well are the ones that are getting good quality resuscitation. Yeah. So you have that whole big package. And all of these factors that we're talking about in that memo, they're about sort of helping you with your clinical acumen of, am I doing well staying here, or should I really just get going?
Yeah. Type thing. Yeah. And I mean, we, quite honestly, these are the things that we did years ago, and then we'd call in and self-report and say, hey, I left early, and then there was a lot of discussion, but it was fine, and now it's come full circle. So that's and I think from the aspect of documentation, and I've seen this through the auditing process, is that what we should be doing is saying on our form, I left early because of distance to the hospital. I had a younger patient, or there's no ACP backup. I had a long drive. I had a PEA. Whatever one of the reasons are, go ahead and just, you're good with that, right? As far as like document it down on the form, and then you're good to go. Because it explains it. You said, this is my rationale why I've left. You don't have to specifically say, according to the June 2023 memo, I left because of bullet point 4. If you want to do that, great. But that's not the point. The point is just document it down. And I've seen this, and it's fine, because that's the decision making you're doing. And that's fair, right?
You got it. Yeah. So just to highlight sort of the timing, you don't have to wait 20 minutes on scene of resuscitation if you have a patient who doesn't meet the TOR criteria. You can leave before then. Sort of SWORB Medical Council suggests a minimum of 4 before you go. And that's to sort of help you have some resuscitation on board before just picking up the patient and going. If you fit into the primary clinical considerations, so outside of this memo, but back to the medical directive, so those reversible causes, then you leave a minimum of 1.
Yes.
If you have a refractory shockable rhythm, then you stay for at least 3, unless you're part of the study protocol, in which you might stay for longer.
And that's a whole other thing. That's not, that's the services do that. So there's kind of a theme that, like, is this going to be put into version 5.4, like these memos? Is this going in here?
That's a great question. And that's the plan, is to have that as part of the companion document going forward for 5.4. So it won't just be living in memo world, it will be living in the companion document as well.
Okay. Awesome. So that's great. Thanks for going over those memos, and it's good to make sure everyone's on the same page and we're all doing what we're kind of supposed to be doing there. So
you got it. And so now we're done talking about, my goodness, now we are done talking about the memos. Yep. And now we're going to move on talking about some of the changes that are going to come into practice that you've learned at your fall MCME with regards to ALS PCS 5.3 being Suboxone. So that's coming up next.
Okay, so now we'll talk about Suboxone. It's interesting, and the way I kind of think of it is that it's an auxiliary medical directive inside of a core medical directive, and it was kind of put in there right in the middle of COVID, sort of. That's when it kind of slid in there, and some services are going with it, some services are not, and there's a lot of questions and around that, like, is this going to work? How's it going to shake out with the folks on the street and stuff like that? So I mean, we are in that opioid crisis. We have been for a few years now. Like, the numbers doubled basically in the last 2 years, and there's all kinds of contributing factors to that. But so, like, can you just talk about the Suboxone and kind of in a more of a succinct thing, and we'll just go over it again just to make sure we're good?
Sure. Yeah. So I'll try to keep it brief because this is a recap for you. But just to get into just a touch of the pathophys, Suboxone is a long-acting, so it reduces withdrawal symptoms and craving because it lasts a long time, high affinity, and then it blocks the opioids from binding, and a partial agonist, which means it has a small effect but a low overdose risk. So it's not the same as, say, heroin or morphine. And all of that happens at the mu opioid receptor. Yeah. So let's break that down. So I know I kind of did, but we'll break it down one more time. It's a long-acting, so it lasts 24 to 36 hours, so that's why it's a once daily dose. It's high affinity, and then it blocks other opioids from attaching to that receptor, and therefore stops them from turning that receptor on. And lastly, it's a partial agonist, which means it gives a small effect, but it doesn't give the same effect that you'd normally expect from that receptor being activated, such as if you use, fentanyl, for example. So Suboxone stimulates the same type of physiologic response as other opiates, but to a lesser degree.
Okay.
For example, it causes much less respiratory depression and euphoria when compared to other things such as fentanyl.
Right. And, that's awesome. Thank you. Now, so it binds to that mu receptor, the I just say the opiate receptor. That might be the easiest thing, right? And then, what it does, it kicks off like all the other opiates, right? Because it has a greater affinity. And with that, he said it basically doesn't give them that same euphoric or that high effect, but it kind of has the receptor. It gives them sort of that effect, but not to the point where they can't coordinate and things like that. And it doesn't really affect their blood pressure, breathing rate, their level of awareness. Is that, yeah? That's
a fantastic summary. Thanks so much for that.
Okay. So now, and talking about the physiology, with this stuff really helps because it's good to know the the dynamics, the kinetics of the drug. But now, and when we're thinking about all that, when we think about like the naloxone or Narcan, when we think about the toxicity, so how does that all kind of fold into this?
And that's a great question. So just to help understand that full pathophys component. So naloxone works by being an opiate antagonist. So it attaches and doesn't cause any effect of that receptor. So it knocks everything off. And you've seen that if you've ever used it. If somebody was having an opioid overdose, they are low and slow. Their heart rate is low, which is why we use the naloxone. And they're unconscious. You give them that naloxone. It unseats all of that opiate that's attached to that receptor. Okay. And then boom, you have no effect of that opiate receptor. So they are awake and they're angry. They are not happy with things.
Right. Yeah. They're not good.
That is how it is different from, say, the Suboxone,
right,
which knocks things off but doesn't cause that antagonist effect because it is a partial agonist. So it gives just a little bit, but not enough to give that full respiratory depression, altered LOA.
Right. And there's naloxone in the Suboxone itself, right?
Yes, there is, Dwayne, and thank you very much for bringing that up. Yeah. So Suboxone is buprenorphine and naloxone together. So where that naloxone piece fits in is that when taken orally, it has almost a full first pass effect.
Okay. Yeah. So first pass. So what is that? Can you just explain that just one more time, just so we know the first pass stuff?
Of course. So first pass effect means essentially when you take it in, it talks about how it's metabolized through the GI tract. Okay. So if you take it orally, it almost all gets taken up and metabolized before it can get to its end location and exert its effect. So when taken sublingually, like you do with Suboxone, it has none of the naloxone effect. However, if somebody decides they want to try to abuse the Suboxone and say inject it or snort it, then it goes directly to the receptor and causes that antagonist effect. So it's unpleasant, so it helps to reduce the substance abuse potential for Suboxone. So people try it once and they're like, nope, not going to do that again.
Okay. No, thanks, because that's important to know about how the different modes of entry and how they get into the body and how they metabolize out. Thank you for doing that.
Anytime.
I appreciate that. So if the naloxone is in the Suboxone, exhibits no effect, so what's the point? Why are we using this? Like, what's the use of it?
In the Suboxone?
Yes. Yeah.
So it's just to help deter the abuse of Suboxone.
Okay. Okay. Well, that kind of makes sense. But they'll still get a little bit of effect. Is that right? Like, is there a chance that they can overdose? Like with this?
I see. With the Suboxone?
Yeah.
Gotcha. So we're talking about, is there possible that partial agonist causes some overdose effect?
Yeah.
Okay. Gotcha. So the chances are very low.
Okay.
Where we might see it is if you have concomitant downers at the same time.
Oh, okay.
So things like benzos or alcohol.
Okay.
So it's not the Suboxone itself. It's more the combination of the whole picture of that sort of multiple downers, if you will.
Okay. So like a polypharm type of thing that hit the same kind, not the same receptors, but more of the same effect that they're designed to do that. Now, another thing, sorry I'm asking so many questions.
No,
what about this precipitating withdrawal? Can Will that happen with Suboxone?
Gotcha. And that's a really great question. So it certainly is possible.
Okay.
And this is one of the reasons that it's important to truly make sure that the patient is in withdrawal themselves before administering the Suboxone. And I swear to the audience, since last we tuned in, I had a visit to the dentist. So that's what's happening.
You're doing fine. It's great.
So yeah, maybe too many sweets, but I mean,
well, why not, right?
It is what it is.
It's fine, yeah.
So there is a safety net built into the medical directive, and that somebody has to have been reversed by naloxone in order to receive Suboxone. And then you need to make sure that they have a COW score of greater than or equal to 8, which means that they are in withdrawal. So what happens with precipitated withdrawal is that when a patient does still have some lingering opioids in there, and then they get displaced by the higher affinity drug, even though it's that partial agonist, so that buprenorphine component of the Suboxone, that the patient can then enter a fierce withdrawal state. But that only happens if they still have that initial opiate attack, so say fentanyl. And so that's where the safety is built into the directive that you have to be reversed and already withdrawing before you're given the Suboxone.
Right. Okay. Well, that makes sense. Now, what happens, like, what should we do, like, when this really occurs, like when they're in those withdrawal states, like what should we be thinking of?
Gotcha. So if this does happen, if you do precipitate withdrawal with giving the Suboxone, then the best practice is to deliver more Suboxone. And that's why paramedics are authorized to give 2 doses. If you believe the patient can benefit from further, then you can pass to a BHP at that time. That's written into the directive as well.
And then if we have and what was taught to us at the research, like the MCME, the first dose is 16 milligrams. We need that second dose, it's 8. And then that interval is like 10 minutes, right? Based on the COW score, if it's still 8 or above and you don't need much to get there. And even though it's new for us in the field, because we haven't had this before, where else is this? Where do we see this Suboxone used, like outside of the EMS world?
Gotcha, and that's a great question. So we are really seeing it used more and more. So certainly in addictions clinics, as well as directly in the emergency department as well, because we're really trying to help decrease the burden of the opiate use disorder. It is different from, say, methadone, where you have to have a special prescription license in order to prescribe methadone. So the nice thing about Suboxone is that it is more readily available for practitioners to start. It's not just medication that's given at addiction clinics.
And as far as the Suboxone, how does that compare to methadone as far as like how it works, like the strength? Like what are we thinking about for treatment here?
Gotcha. So methadone is that older drug. From the medical standpoint, we talked about how you need the special prescription. Other things to kind of know about it is that it is a contraindication.
Yeah, I saw that.
And so the reason that is that you help ensure that the patient doesn't go into precipitated withdrawal, because methadone itself binds to the opiate receptor and does somewhat similar when it comes to the partial agonist effect that Suboxone does. It's a little bit of a dirtier type drug, if you will. And it does last 72 hours, which is why there's the contraindication of you have to wait 72 hours until the patient has taken their last methadone.
Because it'll still hold on the mu receptor.
You got it.
No, that's a lot of, for a lot of folks, it's a lot of pharmacology, it's a lot of patho. But it's good. I mean, if we're giving a medication, we should know not everything about it, but a good deal about it to say, okay, this is why. It's not just, well, don't give it because of this. Well, why? Well, just don't give it. Well, what's the reason? Well, I don't know. Like, it's good to have that. This is what's going to shake down if this happens, right? And last thing we want to do is if somebody's on methadone, and then next thing you know, we give Suboxone because, we forgot to ask or we didn't ask. And then now it's horrible. Like, it's a horrible withdrawal. Probably not life-threatening, but they're going to feel horrible.
They sure are.
Right.
They sure are.
So, is there anything else we should be thinking about as far as Suboxone? Anything you want to talk about to add to this, to say, hey, when we're out in the field, like, is there anything we should be thinking? Or I
think one thing to remember, and it's not written explicitly into the medical directive, is that you can give somebody Suboxone if they've been reversed by naloxone from somebody before you get to the scene. So
Right.
it doesn't have to be the paramedic that provides the naloxone. It may have been a bystander or another first responder. There do need to have the reversal of naloxone for that reason that we talked about, so you don't initiate that precipitated withdrawal.
Right.
But the naloxone requirement of giving the Suboxone doesn't have to be directly from the paramedic.
For me, yes.
But it does have to be from the same acute opiate overdose.
So they basically took drugs, they overdosed, they got Narcan, naloxone.
Yes.
Now they're withdrawing.
You got
It's not like took drugs, got Narcan, withdraw, took more drugs, got Narcan again. It's got to be the same episode.
Exactly.
It's sort of like chest pain. Like, right? That's how I equate it. It's like chest pain where you can give 6 doses of nitro for each episode of chest pain. So if the chest pain resolves and then comes back, we can repeat the nitroglycerin. But in the case of this, we're not going to. Is that that's the way my brain kind of works. I don't know if that works for everybody out there, but anyway. So yeah, no, that's awesome. That's awesome. I know that there was a question, and one of the big questions that's come up, and we've talked about this before, is the effect of, or the environment of, you arrive on scene. This is the one question I have. Just want to make sure we're all on the same page. So you arrive on scene and the person says, I'm not going anywhere. I just want just give me those films, those tablets, those dissolvable wafers. I want that Suboxone. What do we do? Because we've had a lot of discussion, like, we want to treat the patient, but we're, dispensing, that's a pharmacist thing. And, the argument comes up, well, we're dispensing. Well, we're actually not dispensing. We're administering medications based on standing orders under a physician's license. So what do we do when we get into those situations where the patient is probably uncomfortable, not wanting to go to the hospital? Do we give the drug? Do we withhold? What would we think would be best practice?
And this is something that's another memo.
Yeah.
Which is, important because it's a dynamic process working with these medical directives and starting a new drug and trying to properly address and help the population as a whole. And so what essentially SWORP has come out with and said is that if there's somebody who says they don't want to go to hospital and you think that providing them the medications such as the Suboxone will help them make a subtle decision because they're withdrawing, then it's okay to give the Suboxone.
Okay.
So which is different than pretty much any other direction that we've given in the past with regards to dispensing. Is there anything else you want to add regarding the information from that memo, Dwayne?
I think it's a thing. The one thing with that, if I recall correctly, is that, if that happens and say you're going down the path, okay, we're probably going to go to the hospital and we're treating away. And then they finally just say, you know what, Lauren, Dwayne, get out of my house. We're done here. We just document the heck out of that. And I think also if it's a case where we get to the hospital and then they decide they just hop off the stretcher and run, people have a right to make a choice. And that's okay. But what we do is we document that. We tell the emerge staff the patient has gotten off our stretcher and they have left the premises. I'm not sure where they're at, and just making sure that that's all, and document the heck out of it. You can always call in too and self-report. Hey, just let you know this is what happened. Is that that's what I'm thinking. Yeah. Is there anything else that you were thinking about on the memo piece with that, or is that kind of it?
Nothing to add other than we will link the memo to the show notes so that way you can see that there. Some of our services took their MCME in the spring before the memo came out, so there was a bit of a change of direction there. So we'll link the memo so that way you can see that, but we are trying to look at it as a holistic piece and what's best for the patient. And so Suboxone is being treated slightly different than any of our other drugs in the medical directive. So check out the link to that. And send us any questions.
It's not, I don't think there is a simple answer. I think we just do the best we can with the best intentions based on what we're legally allowed to do, what we're supposed to do, and, treat the patient. And if they say, get out, well, we leave. They really stress the fact of it's probably going to wear off in a bit, like, 24 hours anyway.
Yeah, there always has to be that, informed decision making, and people understand the choices that they make and understand that if they're given the medication, sort of what that means for the time course of what their symptoms could look like, etc.
Okay. Well, thanks for clearing all that up there. That makes sense.
So. And that is Suboxone.
Yeah.
And that is the end of the new part of ALS PCS 5.3.
Yep.
So as we sort of touched about at the beginning, this is an auxiliary medical directive within the core medical directive. Core medical directive is already at play.
Yeah.
The auxiliary part becomes live when you're authorized with, as long as your service picks it up and you're authorized by base hospital. The next round of topics we're going to cover are for ALS PCS 5.4. So you would have heard about them in your MCME, but they won't go live until the projected date of February 1st, 2025.
Yeah.
So that's what's coming up next.
Perfect. Thank you.
Thank you. Okay, so switching gears to now to ALS PCS 5.4, and it's content that was taught at your MCME.
Okay. So there was a lot. There was a plethora. That's how I like to describe it. There was a lot going on. There were a lot of things that were introduced, and there were changes midway through, as we see, right? With everything that we were doing. So can we just kind of talk about that, just so everybody has that perspective of where we're going with this now?
Yes, of course. And this year's MCME was designed to cover in depth the content that's coming out for ALS PCS 5.4.
Right.
So February 1st, 2025 is when it's supposed to come live. As we develop the medical directives, and as you've seen, I'm sure, within your career as a paramedic, the changes happen slowly when it comes to how the directives come out. In order to get ahead of that lag, we try to teach the content before the ALS PCS comes out live. An example of what would happen if we didn't was, say, Suboxone. So Suboxone came out very quickly from the ministry. It was released with ALS PCS 5.3, which was February 1st, 2023 release. We weren't able to get to teach it until spring 2024 at the earliest, and for the majority of our services, not until fall 2024. So for some services, it's almost an entire year. Although the information is live, the medical directive is live, people aren't authorized or certified yet until they have their content from the base hospital.
Right.
So we plan to teach the material before the ALS PCS version comes out, so that way you can start using it right away, giving your patients the best care possible. Downside when that happens is that if there are any changes made to the proposed ALS PCS 5.4, that we then have to go back and say, some of this, what we have taught so far, is not going to go live. This is what we're doing instead. And that's what happened with 5.4.
Yeah, and that kind of makes sense. I'm glad at least you've kind of clarified it up. But because there's a lot of information, a lot of content. There's 1,900 of us out there. And we want to make sure, I think what you're saying is too, is everybody's trained up, ready to go with the anticipation that this will happen.
Yes.
Is that,
This year, one big change that happened is that the pelvic binder was going to move from the BLS to the ALS PCS, or the OBEG at MAC had proposed. The ministry came down and said in the late spring, early summer, said, no, we're going to keep it in the BLS PCS. So some services that received their training in the spring would have had some information regarding that pelvic binder moving to the ALS PCS, which then included certain indications, conditions, contraindications, as all of our medical directives do. But since it won't be moving into the ALS PCS 5.4, all the services that are taught in the fall won't receive that information because that is not what we'll be doing in practice. Right.
And, that was the thing, like, a bunch of services went forward and we went over the pelvic binder, all the stuff involved with that. But at least now this will help, clear up any confusion that's associated with that. Because that's important, because you have people working in multiple areas. Okay, what am I doing today? Right. And at our fall MCMEs, we're talking about the pelvic binder and kind of reviewing how to put it on and just troubleshooting and practicing and stuff like that. So, and I think that's a good thing, right?
And if you haven't had your, MCME already. You get to learn about some pretzels and how your bony anatomy is similar to a pretzel. So
it does look like a pretzel, right? And generally, I mean, some folks out there were able to break the pretzel in one spot, and I said you can't take it and saw it on your teeth like a blade, but they were able to gently. I said, but think about the force involved with that. Yeah. Like that's that when you, and I always say the term, you shattered, that pelvis is shattered into multiple areas, right, and multiple fragments. So no, it was good. The pretzels were there, and we basically had a fresh bag almost every time, so they were good too. So, but a lot of new content, Lauren. It's the MCMEs, the research, they've been busy. We've talked about, like, we're going over the pelvic binder, which is not really part of that, but it's more of a, hey, let's just practice it. We also been covering the gastric port suctioning, the TXA, the patella reduction, and then for the ACP folks in the room, myself included, ketamine utilization. Like, it's a big day.
That's right.
It's a big day.
You got it. And we're going to touch on each of those components later. Yeah. Just want to hammer home the point when it comes to the pelvic binder that your practice as to when to put it on is directed by the ALS PCS, so that has not changed. That the stuff we're covering during your MCME day are just best practices and how to apply it, and then just a little bit of background information on sort of where a hemorrhage could potentially be coming from with that pelvic fracture. So your practice doesn't change per se. We're just sort of highlighting some of the best practices and how to apply that.
That's awesome. That's awesome, Lauren, because really it's, we don't use them every day. Not every day, but I mean, when we use them, they do work, and you reiterate the other thing is a sheet, and and that's fine, right? It'll work out. So there's a lot going on.
There is
a lot going on,
and we're going to jump into the brand new content for ALS PCS.
Yeah,
starting with SJ sectioning.
Okay. Okay, so we'll talk about gastric sectioning.
All right.
Let's do that.
Let's go. Dwayne, tell us what's new.
So first off, it's been renamed from the endotracheal tube and tracheostomy suctioning and reinsertion medical directive to the advanced airway and so I have to read it. Advanced airway and tracheostomy suctioning and reinsertion medical directive.
A rebrand.
It is a rebrand. So suctioning through that gastric port if it's available. So we have to remember the reason we're doing it, and the conditions to meet is that there's those secretions that are like, or emesis kind of coming up into that gastric port. And what we're worried about is displacing that eye gel from being moved around, right? We don't want that. We always want it. And what that does, because it's basically cups up and seals the cords, it's going to displace. Now we lose that seal. So now we can't ventilate properly. There's really no contraindications to the suctioning itself. Mm-hmm. So it's pretty linear, but we'll get into it here.
So if they meet the conditions then of that known or suspected gastric secretions or emesis following placement, so the after, so they already have that SGA placed.
Yep.
And then the other component, as you mentioned, is that it's already placed and now you have difficulty with secretions. So it's not just secretions, but it's secretions that are causing the inability to properly ventilate. Exactly,
because the way that kind of sits up there is if it's not sealed properly, then you get those thin secretions that kind of make the seal kind of moves away. It makes it difficult to ventilate. And then when we start thinking about difficulty in ventilation, like how, as a physician, how would you describe that when we start thinking about difficulty in ventilation? Like, what would you think?
Gotcha. So it's not just thinking about it being the seal. I think that's the important part, and it's what we try to teach at MCME, is that when the gastric secretions, they might be one of the causes, but you want to think about what else is going on. So is there an improper device size? Is it an incorrect depth? Is there a lack of pressure, either in posterior or inferiorly?
Yeah.
Or is there gastric obstruction? Basically, these are all things to think about for reasons that difficult ventilation is going on. So not just the suctioning. you want to think outside of that as well.
Outside the box. And then so we think about that kind of brings us to the clinical conditions. Like, I'm just going to read it verbatim so I get it right, because I know in my brain what I need to do. But anyway, some people need that stuff. That's fine. So when gastric secretions are not evident, consider other causes of difficult ventilation, improper device size, incorrect depth, lack of the pressure, like you said. And then it says once that fluid clears, or if no fluid appears after the 15 seconds, turn the suction off, right?
Gotcha. So fairly straightforward understanding when to use it. The wording in the clinical considerations that you just took us through really reiterates that pause to consider other factors. Yeah. And Dwayne, did we talk about sort of anything to think about in MCME to help you remember that?
Yeah, so we use the DOPES acronym. And it talks about different reasons in getting into why this is not ventilating properly, or poor ventilation. So, do you want me to just kind of go through it?
Sure, I'd love to.
So like the first one is the displacement. So is that iGel displaced? And we talk about that. Like, look where the bite block is. Look where the head harness is. Use your end tidal. An end tidal tells you tons of stuff about what's going on with their exhaust. Are they exhausting properly? Then we think about obstructions. Is there a big hunk of ham stuck up in that iGel where we got to pull this thing and start thinking about other stuff, right? Is the patient now biting on the tube because they don't need to be in cardiac arrest? They just have to have no intact gag reflex, right? You need a little bit more airway management. Then the P, so pneumothorax. How are we treating this? How do we determine that? Listen to the chest. Right? That's why we have a stethoscope. Listen to see what's going on. Is there air entry? And then there's different treatments for primary care paramedic folk versus ACP paramedic folk. Then we start thinking about the equipment. Is the equipment working? Is it attached properly? Start at the patient and work our way back towards the wall or to the monitor, so to speak, that we were all taught way back when. And then why we're doing this is because of secretions right at the end of DOPES, the S, right? Secretions. So anything to add to that? We talk about this in a little more context during the MCMEs, but is there anything we think we need to add? Or
maybe I'll just give a bit of background as to why you weren't able to suction prior to ALS PCS 5.4. So you might have been using an SGA that has a suction port, and you might have had suction tubing in your ambulance for a long period of time. But the reason that you weren't able to utilize the suctioning with the SGA prior to the medical directive coming out is that it technically is a medically controlled act. So putting an instrument, hand, or finger beyond the larynx is a medically controlled act, and therefore needs a particular medical directive that is, overseen by and delegated by a base hospital physician. And now that it's written into the rebrand medical directive, as long as you are authorized and certified to use it, then you can go ahead and use this medical directive.
Okay. And with that, I think most folks, all services now in the SWORBHP region are carrying the iGels. And I do have that conversation asking, before we get started, I kind of say, hey, how are these iGels working? They seem to be pretty slick now. We're not promoting any particular brand of equipment, but they do seem, once they're placed and secured in place, and we kind of do some stuff there with how to put the little foam head harness on, maybe tape if necessary. Everybody has different equipment in their service, like maybe tube holders and that, but they do seem to work pretty good. Once they're seated, it's there and it's venting. If it may not be it's not as effective as an endotracheal tube, but it does seem to work well. We don't have to worry about inflating cuffs, nothing like that. But I think all services in SWORBHP are using them. Every single one. I think that's the only SGA that's being utilized now. So that's why we are talking about it. It does seem, once it seats and goes up around those cords, and once you have it secured, your end tidal on, it's tied into place, and you're venting, it does seem to work not too bad. It works pretty good. At least that's what I'm finding.
And that's what we're hearing as well. And so most of the time it works fantastic. The reason for this medical directive is just to help when you do have some of those secretions that, just like you said, are moving it around. We're going to throw a photo of a sagittal cut of the iGel into the show notes, so that way you can see exactly what that looks like and what we're talking about when it comes to proper seating. But in the meantime, Dwayne, can you tell us how to utilize this medical objective.
Okay.
The actual procedure treatment itself.
Yeah. So once you have that eye gel, so again, we're taking care of the patient. We always check the airway first before we drop that eye gel in. We make sure that the airway's not full of stuff. This eye gel suctioning is different than regular suctioning, because regular suctioning, we follow the normal suction rules. Like as far as length and depth, we never suction further. We can see if we're going down the hole of an oral airway, earlobe along the angle of the jaw, the corner of the mouth, that's our depth. We go down. If a nasal airway, earlobe along the angle of the jaw, the tip of the nose, that's our depth to go down. We always suction with a sweeping motion upon withdrawal of the catheter, no longer than 10 seconds, because suctioning not only removes secretions, it pulls out oxygen as well. In this case, because once we clear that airway, if the airways are technically flooded, we clear all that out before we drop that eye gel in. As long as there's no other contraindications, eye gel goes in, we get it seated. Now, if these secretions, and I don't want to say clear secretions, I just rather say thin secretions, like watery secretions, because you could say, well, if it's not clear, what if it's it doesn't matter about what the color is, it's the viscosity, the thickness of it. It starts coming up that gastric port. So what we do with that is the way we're supposed to measure it, and it's a suction catheter. It's not an NG tube. It's a suction catheter. So what we do is we have that lube there and everything. So what we will do is take the catheter itself, and we use the cradle. So for primary care paramedics, I'll address this first. We go about an inch or so past the rounded end of it, go to the base of the cradle, put your fingers there, mark it with a piece of tape. Then we put a blob of that lube on the gastric channel opening, the port that we used to cover over during COVID. And we kind of get the catheter a little bit lubed up. We kind of introduce it back and forth because remember, it's plastic on plastic. And then that piece of tape, you introduce that now nice and slowly until you get to the taped portion. Now, a little trick, because you want it, once it's there, you want to leave it in place. Take it, fold it over, put a piece of tape around it. That way it's there. Then you're going to set up your suction. So you have your suction, and it's the same millimeters of mercury torr for this as it is for trach suctioning. So if it's birth to 1, 60 to 100. 1 to 11 years of age, 100 to 120. These are all millimeters of mercury torr. Then 12 and above, it's 100 to 150 millimeters of mercury torr. Set that pressure up. It's always recommended to start a little bit lower, then work your way up as needed. So now remember, depending on the equipment your service has, if you have the little double-ended connectors that hook up to the suction tube itself, if not, you're going to be, essentially, I say you're mainlining it right onto the little elbow. And then once you turn the suction on, it's pulling. It's like a vacuum. It doesn't stop until you shut it off. Now, kind of the guidance or best practice is that if the secretions are still, it does say 15 seconds in the directive. But if there's still stuff coming up, just leave the suction running. You don't have to shut it off at 15 seconds. If it's still going, just keep. The reason you want to be cognizant of not too much suctioning is because it could possibly, once the secretions are gone, that's why they say 15 seconds or until the secretions are clean. You just don't want the esophagus to go like that. And then you vacuum, like you create a negative pressure in the esophagus, which could cause trauma, ischemia in there. But really, the greater risk is if there's still stuff coming up, and it's still suctioning, let it roll until that's cleared out and the secretions stop, then shut it off. And there's no minimum times, there's no maximum times. If you need to do this, just go ahead and do it, and that's totally fine. Now for ACPs, so ACPs, it's a little different animal. So we're all taught something a little bit, maybe a little bit different. So basically, we take that suction catheter, we go from essentially some say to the umbilicus, some say to the xiphoid process. We go up, go to the nose, around, this is what I was taught, around the ear twice. That's my depth. Put the piece of tape on. Again, little bit of lube onto the gastric channel, introduce that, and then start feeding it down. Now, this, again, for the primary care paramedics, we're going to be about an inch into the esophagus. For advanced care paramedics, because it is a Schedule 3 act, and we were all trained in it. Now we're actually got to have the green light to do this. We're actually we're going down the esophagus, And I just want to go on record. We're not evacuating the stomach. What we're doing is we're getting through that first sphincter, which is the cardiac sphincter. And basically we're basically pulling the clear secretions as well as maybe extra gases that might be in there that have inflated that, which may impede breathing and diaphragmatic movement and stuff like that. And so that's basic, and it's the same rules. 15 seconds. If there's still stuff coming up, keep suctioning. And again, it's just important that we document this stuff down, mark our depth. Like these suction catheters generally don't have, it's not like an endotracheal tube where it has centimeters up the thing. That's why the tape is important. That way you can say, yeah, it's in this far. And some people say go to the umbilicus and then go up and around and then do it. Depends when you went to ACP school, how you were taught. I was taught, and it's fine either way. I don't think there's a real big difference. Xiphoid process, up to the nose, around the ear twice, just not big loops, small loops, and then that's the mark, and then go from there. And that's basically that. But again, this is something we're not using until February 1st. This is if the secretions are there. And that's just what I want to kind of talk about. I hope that's okay. I kind of rambled on there, but that's basically how you do it. That was
a great rundown. That was the whole procedure itself, plus the difference between AC, PCP, and covering. One thing I'll just really hammer home is that for the ACPs, it's not meant to be an NG tube.
No.
So it's meant to help aid the airway when it comes to that air. There's a big gastric bubble or those thin secretions. So again, not the color. Fantastic.
Yeah, thin secretion.
That's perfect.
I kept saying clear, and some people said, well, what happens if I say, it doesn't matter if it's a color of Mountain Dew or if it's clear. It doesn't have to be crystal clear. It's just thin, right?
That's the key. And there's two quick things that I want to touch on when it comes to the medical directive. So the first thing is the wording of following. So when we're saying following, it does not mean that the patient must only have secretions after insertion of the SGA. And you kind of alluded to it a little bit earlier there, Dwayne. So you can suction out a whole bunch of secretions before you put the SGA in, but you're not using the SGA in order to suction the secretions out, the port, in order to suction the secretions out as you insert the SGA.
Correct.
So the following part is not that they don't have any secretions before. And it doesn't mean you're using the SGA with a suction device built into it with the port.
Right.
It means that they can't have had secretions before that were then cleared. Now you've placed the supraglottic airway, and now you're concerned that it's not seated properly, potentially because of some of those secretions. So that's what I wanted to touch on when it comes to the word following.
Okay, so that makes sense. What's the second? You said there's two.
Yes. So the second part is with regards to the gastric secretions or MSS to clear. So it's not designed to remove those foreign bodies. So when we talk about those clear secretions, it's that thin secretions. The gastric port suctioning will not remove the foreign bodies. So if you think about the size of the suction tubing versus the size of an NG tube, you've seen it. So big, much larger bore. So when we're talking about vomit in the airway, this is not for that. This is for those thin secretions. Okay. If you do have vomiting in the airway with the supraglottic airway seated in, then you have to remove it in order to properly get rid of those foreign bodies. Okay. And then reinsert once it's clear the supraglottic airway.
Now, as far as that, catheter, yank it or leave it in place? What's the opinion on that? If you say I pull the eye gel, I suction out all whatever's coming up. It's thick, like heavy stuff. Now it's clear or it's empty. The airway's now been vacuumed. Right. I have that catheter still in place for primary care and advanced care. Pull the catheter or leave it in.
Gotcha. And I can see that route of thinking. You're like, I already have something that's going to suction a little bit. Can I not just bring it out with the supraglottic airway in hopes that we're able to suction it out? But the best thing to do is just remove it. So what can happen with that suction port is it can become coiled or affect the positioning or cause tissue damage as you pull it out. So the suctioning tube must be removed when inserting the supraglottic airway, or as well when you're taking it out, you want to make sure the suction tube is removed. So basically, if you're moving the supraglottic airway, that suction tube should be out.
Right. Right. Well, that makes sense. Yeah, that does make sense. Now, a question we had during the research in the MCMEs is that, so we're allowed 2 attempts to put in an SGA. So what happens if I had, say, if it was working and now I had to pull the SGA out? Do I only get 1 more?
That's a great question. And this comes to sort of the definition of what an attempt means.
Okay.
So the attempts, you're allowed 2 in order to obtain a successful airway.
Okay.
Once you have obtained the successful airway, if you then have to remove it because of, say, vomit, foreign bodies, so it comes out, you're now back to square one, and you're allowed 2 attempts now because you had success. It's in. This is now a second event.
Okay.
So you're now clear. You have 2 full attempts once it's been removed if it was inserted properly. That makes sense.
Yeah, that does make sense, and that actually clears it up because we always look at the bottom of the protocol in the box, maximum number 2. Well, do I only get 1 more? But if you're saying, as long as it was successful and working and you had to remove it for some other reason because there was just the airways flooding again, then go ahead and get 2 more. That's awesome. That clears things up because that was a common question. And I know we got caught. We're like, I'm not 100% sure. So we'll find out for you. So, but
another dynamic component of the education and things that come up as we're teaching things, we want to make sure we have things crystal clear for you. So there you go. There's the definition of when you can perform 2 attempts, and the complete or successful airway basically wipes that slate clean. If you have to remove it, you've got now 2 more full attempts in order to obtain a second successful airway if it was removed because of that foreign body.
Okay, no, that's awesome. No, that really helps. That really helps. And again, just for the ACP folks, I just want to go on record. We're not endorsing any particular way. Start here. Whatever you were taught is fine. Everybody comes from different schools and different times. But once that's in place, again, it's not. We're going a little bit in past that cardiac sphincter, and it's more to pull those thin secretions out, and probably the gases will pull out of there as well, and that'll help with diaphragmatic movement and expansion and dropping. And again, we're not evacuating the gut. We're just getting the thin secretions out of there so that way it doesn't disrupt the seal, so we can provide good ventilatory assistance with the patient. And we follow those same rules. It's the same 15 seconds. If it's still coming up after 15 seconds, if it takes 30 seconds, that's fine. Once the secretions stop, then shut it off. But we don't, because we don't want to be turning things on and turning things off, because that was kind of originally how it was written. And then we got some clarification on that and said, well, why bother? But I was saying, well, we just want to make sure we're doing the right thing. And for the primary care folks as well, if it's still coming up, just leave it running until it's done, then shut it off.
Perfect. That's great clarification. And you did a fantastic job of running everybody through the procedure.
It's straightforward, right? I think once you've done it, and you get comfortable with it, and I think getting your hands on is the big piece, right? That hands on is the most important thing.
And we'll have a link on the show notes as well. It takes you step by step through that procedure, just for more things to add to the show notes as we cover more and more material. Speaking of that, next we're going to move on to another item new to ALS PCS 5.4, which is the lateral patella reduction.
All right, so patella reduction, brand new. There was a lot of things happen with this directive, but it is moving forward. As far as talking about it and teaching it to the folks so far, it is, I think that when you actually see that video where the orthopedic surgeon puts the patella back into place, that really brings it home. I think it's something that, I think it'll be a linear process. It's going to be interesting. There were a lot of questions surrounding, well, what about pain? What if they tell you to stop? All that kind of stuff. And what are the risks involved? But I think it's something that's needed because we see this happens. We see it. It's a very safe process, and we see the merge docs do it, and we think, well, geez, I could maybe try that, right? So, but yeah, I think it'll be. It has been. There's been mixed emotions. Some folks, when they see that patella slide over and that's okay. That's fair enough, right? Everybody has that point. But I think it's going to be interesting the first few times that we do this after February 1st.
Yes.
So, yeah.
All right.
Yeah.
Let's dive into it then. And we'll touch on maybe some of the sticky points.
Sure.
Questions and stuff like this.
Yep.
To begin with, where this came from. So the medical directive was tabled following a successful study in paramedic identification and treatment of lateral patella reduction in Health Sciences North Region. So I won't go into too much detail about it, but essentially there was 111 patients that were enrolled and had an attempted patella reduction performed by the paramedics. The median pain score was 9 out of 10 initially and down to 3 out of 10 after reduction. And the reduction rate was very successful at 87%. Yeah, so that sort of was the onus to saying, you know what, it does sound like this can be done in the pre-hospital world. It can certainly help patients bring down that pain.
Yeah.
So let's roll it out with the medical directive. Dwayne, have you ever seen a lateral patella dislocation before?
Yeah. And I was like, oh, okay, that doesn't look right. But what I'm going to do, I'm going to split that on both sides of your legs, and we're going to go to the hospital, and here's a little pain medication. And, you kind of, and then when you see it, it's when they reduce it, you're like, I could have maybe tried that. But anyway, yeah.
So it is the most common form of patella dislocation. So 90% of all the patella dislocations are going to be the lateral way. And that's just based on the forces that are basically put on the kneecap itself. It's most likely going to slide laterally. Dwayne, have you ever seen a true knee dislocation?
Yeah, a few times. And it's horrible. It's like that. Yeah, it's not good.
It's not good. And the key to the directive and the key to attempting reduction is when you are quite certain, or as certain as you can be, that it is truly a lateral patella reduction. Because lateral patella, it doesn't involve the knee joint itself. It's the kneecap over top of the joint that slides. Versus when you get into things like the true knee dislocation, when it includes a lot of force and just causes massive derangement inside the joint. Tell us about the times that you've seen the dislocated knee. What was the mechanism then?
So there was a lot of force involved. I think every time was motor vehicle collisions, or they got ran over by something, and the part of the leg that they just separated. Like it was, yeah, they're pretty horrific looking, and the patient is just screaming in pain. Like it's horrific. And
we don't want to reduce anything other than a true lateral patella, because you can cause more damage by trying to reduce something that's damaged, like a true knee dislocation. You can cause some severe vascular injuries as well. So with that in mind, let's hop right into the medical directive.
Okay. So the way this kind of works, and is that what's indicated, or how the person kind of meets the directive, is that the patient has a suspected lateral patella dislocation. It's got to be lateral. So lateral, outside left, outside right, not in the middle, not up top, not down lower. We're going to put a picture up there so you guys can see that. So that way you can see that it's out to the outside of the body. And then when you think about the history and your physical exam, we're looking as we're walking up and we're seeing, okay, but the history, we kind of have to take that into account too. So
that's right. And just like Dwayne said, in order to gauge how suspicious am I of a lateral patella reduction, you use historical factors and your physical exam factors. So let's jump into some of the historical factors that make you think this is a lateral patella knee dislocation and nothing else. Yeah.
So like we think about the history, it's generally no direct knee contact, so to speak, and low velocity. A lot of it's like a changing direction. Like you may see that with soccer players. They were going straight, now they want to go left, and they go, and then all of a sudden, boom, out, their patella slides to the outside of the body.
And then that's exactly, so from an anatomic standpoint, you have your really strong quadriceps muscle, so that muscle that's right at the top of your leg while you're sitting down like we are. And in combination of sudden flexion and external rotation of the tibia, that lateral patella, because the powerful quadriceps muscle gets pulled laterally. So it's not because of any direct force, but it's a sort of twist while flexed. Mm-hmm. And that's what causes the kneecap to slide outside and laterally. Is there anything else that's helpful on history, Dwayne?
And it's generally a younger person's game. Can it happen with older folks? It can, but generally with older folks above 50, so I'm out. There's other things like, osteoarthritis can be in there. There could be these little slivers of bones, like an osteocondylar fracture, like a chip that comes off the inside. And that's why you see the age, when we looked at the studies, it's between 12 and 20. That's the big majority of the cases. And that's why we don't go below 10 years of age, because growth plates. We're always worried about growth plates. And could there be something else going on? Plus, their bones are still a little soft too, and things move around. But yeah, that's why the ages they don't go above 50 and they don't go below 10. So generally, it's a younger person's game that we're seeing.
Awesome. So that covers the historical portion to add to your suspicion of injury. What about the physical exam?
So when we get there, we start doing our physical exam, and they're probably sitting. The knee is flexed, the leg is flexed could be a 90, maybe a little bit more. The patella's on the outside of the leg. They have the inability, they can't extend that leg at all. There's a lot of pain, a lot of swelling. It's red and sore there generally because they've probably been holding it, probably ice has been on it, that sort of stuff. But it's on the outside of the leg itself. You see that that patella is bigger than what you think. It's actually out right on the outside. It's a good size.
And I'll just throw in another plug there to check out the show notes, because the show notes will actually post the photo that you had at your MCME that gives you a really good picture to sort of ingrain in your brain as to what a lateral patella dislocation looks like.
Yeah. Now, when we think about the conditions and stuff like that, we already spoke about the age range and why, and there's only one further condition. The patient must be unaltered in order. Now, why is that? Why does their mentation have to be unaltered?
Great. And that's a great question, Dane. And it really has more to do with the fact that if you had some type of injury that caused you now to be altered from your baseline, you should really be considering something aside from a lateral patella dislocation. So if you had some type of force, or have some type of traumatic brain injury with disorientation that you're altered, it's likely more than just a simple lateral patella dislocation. And that knee injury is probably not something that you should be reducing, because it's probably not the lateral patella dislocation. So just a level of safety, if you will,
right,
to making sure that you're choosing the right patient to do the procedure.
And that makes sense, because the contraindications are like the high velocity trauma or direct knee trauma. Can you comment for context just what is that? How do we define that?
Of course. So the reason that those were put into the contraindications is to help identify the true lateral knee dislocations, or pick out those ones that aren't the true lateral knee dislocations. So as we mentioned a little bit earlier, we don't want to attempt reduction on other knee injuries because there's so many nerves, blood vessels, lots of things back in the knee that we can cause injury if we're sort of moving it around. So since lateral patella dislocations happen in an atraumatic setting, so again, that flexion and twist rather than a direct injury, the history of trauma should steer you away from considering that lateral patella knee reduction, especially if there are a whole other long list of other injuries that could happen, and we're not able to have, x-rays out in the pre-hospital setting.
Right. And then we think about high velocity, like that's always subject to interpretation, right? So, I mean, when you think about high velocity, like, are you talking like getting hit with a soccer ball, or is it more like they got taken out at the knees at a football game type thing?
All right. So when it comes to the actual definition of high velocity trauma, what we've been teaching at our MCME is a significant external force that is acted on the knee. Yeah.
And then it branches into, well, what's significant, right? So, but I mean, it's got to be a lot of force, right? Like to hit. And I think what we've kind of said is that if you think it's been hit, if there was any contact at all, just leave it. And that's kind of, because we just want to be cautious with that. I mean, even it may be presenting flexed and stuff like that, but we just do you think that's the best thing for that?
Yes. So in essence, any trauma to the knee, don't consider doing the lateral patella reduction.
Okay.
We did teach in class that there is a way that you can have direct trauma to the kneecap and have a lateral patella reduction. Okay. So let's say you were hit by the soccer ball to the medial aspect of the knee. That might cause it to reduce laterally.
Yep.
But they would not fall within the medical directive to consider reduction in there. So we're looking for the purely atraumatic lateral patella reduction.
Completely atraumatic. Okay. Well, that kind of makes sense though, because I was going to ask you to talk about that. So, we think about that trauma and stuff like that, and then we think about the patient. They're seated. Sometimes they're on a bench. They can't extend that leg. They can't do that stuff. When we think about treatment, what would you recommend as we start going down the treatment path? What if we're not sure?
Gotcha. So the safest thing to do if you're not sure whether this is a true lateral patella dislocation or not is to not do the procedure. Okay. So we go back to what you're currently doing in today's world before 5.4 comes out. You're splinting, you're providing ice, reassurance, you're giving some analgesia. Those methods, you're not attempting reduction. If you're not sure it's a true lateral patella knee dislocation, you go with what you're currently doing, which is not reducing.
Yeah.
And then you're still treating the patient, you're just not performing that reduction.
And if we are sure, it's to the outside, there was no direct force to it, it may have been a plant and twist, then we can go ahead and treat, right?
You got it.
Yeah. And that kind of makes sense. And we think about how we treat this, and we did go over it in class, and we have the artificial knees there that we're utilizing, and it's kind of good to have the patient seated or laying down, and we cup the outside of the patella with our thumb, so our arms it's gonna be a weird body mechanic, and then at the same time as we're lifting the leg, and generally when you lift the leg, that's when the tendons kind of, because they're stretched, right? So you're shortening the length of them. Then as it rides up over top of that metaphysis and then kind of back into that groove, it seems to do that. And we're going to actually have a video inserted here for you guys just to review it again, where it kind of goes back into place. So you're kind of lifting and doing that at the same time.
You got it.
So
check out the video.
Yes. Yeah.
And Dwayne, how many attempts are you allowed? Because we already talked about attempts when it comes to SGA. What about this procedure?
So we're allowed 2 only per patient. Period. That is it.
So not 2 per paramedic.
No, 2 per patient. And that's it. And what we've told folks is that an attempt is defined as force applied. Again, how much force is force? Basically, if you're starting to move, that's an attempt. That's force.
Right. So palpation doesn't count. So if you're palpating the kneecap to try to determine, do I think it's lateral? Am I sure that this is truly what's going on? Palpation is fine. It's when you provide that external force in your attempt to reduce.
Yeah.
That is an attempt.
Yep.
2 of those. That's what
exactly. Right. 2 of those and go from there. And it's important, remember, do our BLS care, right? Pulses, cap refill, skin color condition, sensation, pre and post maneuver. Also thinking about analgesia, that gets into a whole other animal because generally the pain is reduced significantly after it's done. But it's not a bad idea to get it on board, even though it may take a little bit, right? It's a judgment call at that point.
And from a SWORBHP perspective, we're not prescriptive as to when to give any analgesia to patients. You can utilize your clinical judgment to decide if you want to administer it prior to reduction to get it on board for it to potentially work down the road, or if you want to jump straight to the reduction to reduce that pain. So it depends on everything that's going on around you. Use your clinical judgment to decide what comes first in your unique patient situation.
Yeah, so like I think it's good. I mean, that's gonna, like, I think you hit the nail on the head. It's like, maybe they need it now. Maybe that'll help them relax. There's a school of thought. Let's get some on board. That'll start reducing the pain, that sort of thing. It may be a case afterwards, and I guess that, yeah, it all depends on the situation, right? Like, I mean, really, I'd rather not get the person loaded up with narcotics if I don't have to. But then again, if it's, sometimes I might have to do it before, then it kind of relax a little bit, and then
each situation is unique, and you can use your clinical judgment to decide which way you want to go. There's one thing I want to touch on really quickly. You mentioned your BLS assessment, which is fantastic. So you want to test that distal neurovascular status before and after the reduction attempt. The other thing is, if you, before the reduction attempt, have an absence or discrepancy in the neurovascular exam, that's somebody who we would not suggest going ahead with the patellar dislocation, because that's probably not the true lateral patellar dislocation. It's probably something else going on in there, because your neurovascular bundle is behind the knee, the popliteal part there. So if you're having some discrepancy in your physical exam, the best thing to do for that patient is to transport them to hospital and not perform any sort of reduction attempts on that knee. And
that's a good point, right? Because we just don't want to cause any, if there's no pulse, dorsalis pierce or posterior tibial, or the foot is mottled, something else is going on, right?
Yeah, you got it.
Yeah.
And that's a life or limb to the hospital.
Yeah, so, I mean, is there anything else you want to comment on, or?
I guess the only other thing that I want to add is that there's a really strong visual component. So I'll throw us back to check out those show notes, so that way you can ingrain that picture in your mind as to what a true lateral patellar dislocation looks like, as well as the video of the procedure itself. Yeah,
and now we actually have something that we could possibly do to bring it back in, the lateral patella, to bring it back into place. And, it's another tool in our toolbox. And, if you're at all concerned, if there's a lot of force and you can't do it, then splint is found and go to the hospital.
Sage words.
Yeah.
Sage words.
I think that's good. Well, that's awesome. Well, thanks, Lauren, for that. And I think we're moving on to traumatic hemorrhage.
You got it. So actual trauma this time. Not a traumatic injury. Trauma.
Okay, well, that's great. So now that brings us to our next chunk of the ALS PCS version 5.4, the new medical directive, the Traumatic Hemorrhage Medical Directive.
That's right. And this medical directive is being introduced to give you more tools to help with the treatment of hemorrhage in the setting of trauma. Dwayne, can you tell us what you currently use in the setting of trauma?
Well, so basically we just stop that bleed. So like direct pressure, elevation, encourage rest, regular dressings, tourniquets. We could put a second one on, hemostatic dressings, splinting, fluid. If you're IV certified, we can give a little bit of fluid. But essentially that's what we're doing. The pelvic binder. So if we have someone with a shattered pelvis, we get that binder on to kind of compartmentalize stuff. So.
Gotcha. So a few options to stop the bleed. This new medical directive gives a new treatment to add to your tool belt called tranexamic acid, or TXA. Okay. So Dwayne, prior to this medical directive coming out, have you heard of this before?
So I know when I brought patients to the hospital, they would say the word TXA, and it starts to help with clotting. Didn't really know a lot about it. But can you kind of build on that just so everybody's on the same page?
Sure. I'll touch on it just very briefly from the pathophys perspective, because during your MCME, you're going to have a great presentation. You're going to see a little video with little dogs. It's going to be good. It's really going to help sort of cement that fibrinolysis. But basically, TXA is an antifibrinolytic medication that helps prevent the breakdown of clot, therefore stabilizing the clot and preventing further hemorrhage. So that's as simple as we can get.
And I'm assuming we always work with evidence-based medicine and, best practice. So what is the evidence we have for this?
So that's awesome. And I'll try to be brief here too, because there's lots of layers of this, because it kind of came out and then it came out and then it came out and now it's come out for the pre-hospital world. So we'll cover some of the details from the MCME in brief. TXA has been found to be efficacious in reducing mortality in traumatic patients, first in the acute hospital setting, within 3 hours of injury. So that was the CRASH 2 trial that was published in 2010. So we've been using it in hospital since about then. It then became a mainstay in the pre-hospital treatment. It was then explored for the pre-hospital setting. So that's what the STAMP trial showed. And that's why we're using it now. So it reduced mortality when given within 1 hour of injury in the pre-hospital world. They also give a second bolus in hospital after the pre-hospital bolus as part of that STAMP trial methods. So we do that as well. So we give one dose here, and then you'll see likely another dose being given in hospital. But that's where the evidence comes from. First tested in the hospital world, now tested in the pre-hospital world, and now we're using the same methodology as that STAMP trial.
Well, that's awesome. Like really neat stuff, right? And just stop the bleed in the field. That's important. If we can get the head of that, that's important, right?
Exactly. And Dwayne, can you take us through the medical directive then?
So yeah, absolutely. So again, with all the directives, how they're written, we have the indications of suspected hemorrhage due to trauma, and hemodynamic instability. And Lauren, it said and then, so Lauren, the wording here caused some questions in the class. So does the patient do they need to have trauma, or can they just be hemodynamically unstable?
And that's a great question. So the short answer, the easy answer is they need to have trauma. So if you're not sure about the wording of the medical directive, just look at the title there, Traumatic Hemorrhage Medical Directive. So there must be trauma. You may have seen TXA being used in hospital in the setting of non-traumatic indications. And there are some in-hospital indications for TXA, but in the pre-hospital setting, only for trauma.
Trauma only. That's awesome. Thanks for clearing it up. So when we move on to the conditions within the directive, right, they have to be 16 years of age or older, and they either have to have a heart rate of 110 beats per minute, or they're hypotensive, which is systolic blood pressure less than 90.
That's right. And the reason for these vital signs is we're looking for patients with hemorrhage and shock. So that's why you see hypotension and or heart rate greater than 110.
Okay, and that makes sense, right? So that makes sense because they're dying, they're in shock. So when we go to the contraindications, so there's 3 of them. So with any medication, so an allergy or sensitivity to the drug, or it's been greater than 3 hours from the time of injury, or the time of injury, the trauma when it happened, we don't know. Or there's an isolated head injury, so just the head, nothing else. So Lauren, the first one's kind of self-explanatory with the allergy and such, but can you talk about the other 2?
Absolutely. Okay. So regarding that 3-hour mark, TXA has been studied to be found most effective when given early while the body is still forming that clot to stop the bleeding. Once the 3-hour mark is passed, now the administration of TXA may increase the risk of adverse events, so clotting, without any of the risks of stopping the hemorrhage.
Okay, and then these adverse effects, like what would we expect to see?
Great question. And so the short answer is when you think of thrombotic events, so like PE, DVT, and stroke. Okay,
and that's a lot because the patient's they've been through enough, right? They don't need that. We don't want to add more injury or more deficit. And what about those patients that have like the isolated head injury? What's the deal with that?
Great. Awesome. I'm glad you brought that up because that's kind of a weird one in there.
Yeah.
It's just like everything is generally, like you say, straightforward, the allergy, sensitivity, etc. So the reason for this very particular contraindication is that there's the risk of the thrombotic events.
Okay.
So the risk is thought to outweigh the benefit here. So the sort of stopping the hemorrhage inside the brain versus the increased risk of thrombotic events in the body.
Okay.
So traumatic hemorrhage outside of the brain can cause terrible shock. We see that from a hemodynamic standpoint.
Yep.
But if it's inside the brain, you don't get the same amount of hemorrhage inside the brain. You get compressive effects, but that's different than stopping the hemorrhage of blood leaving the body.
Okay.
So that's why that very specific contraindication is in there.
Okay. And then when we think about the treatment itself, so we can either go intravenous or intermuscular. If we're going intravenous, it has to be given over 10 minutes. And if we go intermuscular, we need to find, basically draw up 2 5 mil injections, and then we start looking for muscles and just get it in, right? Like, so as far as the site, like I know we had a lot of discussion. What's kind of the take home message we want to think about these sites when we're thinking about volume and stuff?
Gotcha. So if you think about this, and ACPs have heard us talk about this when it comes to the Combative Patient Medical Directive when we reviewed that at one of your ACP hands-on day. But essentially, you're looking for, in the clinical situation, whatever site is going to work best for you. So if that's the deltoid or if that's the vastus lateralis, then use that site. Whatever you're able to get to the easiest is the best site to use.
Okay. So like, and I know the kind of in the directive itself, it talks about, the deltoid holding about 2.5 mils, the vastus lateralis, that can vary, 2.5 to 5 mils. And when we think about this, out like from the aspect of non-IV certified medics using intramuscular injections, I guess what you said, like, we try to choose the site that's going to work best for us. Like what's there we can work with.
Yes.
Is that right?
Exactly. And you're probably ringing bells in your mind about thinking, well, am I not supposed to use the vastus lateralis? And in the setting of IM epi, when you're giving it for anaphylaxis, then the vastus lateralis is going to be the best muscle to use. Okay. But in these clinical situations, if you're giving it the IM route, because we're going to touch on IV versus IM next, don't worry about that, because we had some questions at MCME about the route chosen.
Okay.
But if you're using IM site for TXA, it's from the clinical situation, whatever you're able to use to get that medication into the patient.
Okay. So just kind of jumping in here and a reminder, these patients that like they're in shock. So they have to have that elevated heart rate or they're hypotensive or both from the bleeding. So I think the take home message, and I just want to confirm, we don't want to delay transport. We want to get moving, with any major trauma, right? We want it. We do what we need to do on scene. We package up. We get things under control, and then get moving to the hospital. And then that is going to, like, I'm assuming, like either intravenous or intramuscular. Like, there's no preferred work. Like, we're going to do this en route. We're going to figure it out as we go.
And I think that that's the key here. And we try to get at MCME is that this is a new tool to use in your toolbox. But the number one priority for these patients that are very sick, already in shock, are they need to be moving for transport. Right. So you're choosing what route, because I think we're now kind of jumping into the what route to choose for this medication. You're going to use whatever works as long as, you're IV certified. You have the option of IM or IV.
Okay.
If not, obviously, you're going to use IM only. Okay. Is that if you're leaning towards starting an IV and giving this medication IV, that you're not staying on scene and delaying transport to start the IV.
Right. So like all hands on deck. If you have the hands, if you have the time, go for it. If you don't, do it on the way to the hospital, but don't negate other stuff. And then we think about those clinical considerations. When we're talking about the TXA should not be delayed or prioritized over the management of other reversible causes. What does that entail as far as the other reversible causes?
Gotcha. So in the setting of trauma, that may include controlling external hemorrhage. So if you see pooling of blood anywhere, it goes back to those basics of stop the bleed with just compressions, with tourniquet if it's available to you, external pressure. You're providing ventilations and or managing attention pneumothorax for ACP scope. Okay. Basically, if resources are available, treating these conditions can occur concurrently. Okay. But you don't want to leave these primary life threats to focus on this new tool, the TXA.
Right. And, that's a great explanation. Like, if you have the hands, if you have the time, go ahead and do it. If you have multiple people there and they're in the back, if we're fortunate enough, that's great, because this is the gray zone. This is where, should we do this? These aren't crystal clear. They're not black and white. There's just so much that, like, how am I going to be able to manage this on the way to the hospital? So I think it's helpful for everybody out there to think of it as, okay, if I have the hands, if I have the time, use your best decision making. Don't negate doing this to control bleeding or cranking the tourniquet on and holding in order to draw up TXA and give it. I think that's the thing about care, that we have to make those decisions on the fly, and everything, airway, breathing, circulation, all that kind of stuff comes before getting that drug on board.
That's the perfect explanation, Dwayne. The perfect explanation. So ingrain that in your memories, guys, when it comes to TXA.
Right. One more thing I just want to talk about, both for internal and external bleeding. We can't see the internal bleeding, right? We obviously can't that. But we're tipped off by like the mechanism of injury, their vital signs, all that kind of stuff. And external bleeding we can control. But if we're thinking internal, then TXA, that can be added in as an addition to get that stopped.
Yes, exactly. And that brings up a point that was brought up at MCME. We were talking about internal versus external bleeding. And if I see external bleeding and I'm not able to control it, can I give TXA? And absolutely. So the answer with that is yes. It doesn't have to only be internal bleeding that we're using TXA for. If you have external bleeding that you're doing all the things a priori that we talked about, doing your basics, and you still have this person who's hemodynamically altered and fits the condition for the medical directive, go ahead and give the TXA, even if it's external. Internal, external, doesn't matter. If they meet the conditions of the medical directive, go ahead and give it. Awesome. And again, don't delay.
Awesome.
Transport.
Yep.
To give it.
And is there anything else you want to highlight from some of the MCME questions?
Yes, and that's we really want to highlight this one thing is that we just talked about the patient meeting the conditions, but a patient may have trauma and meet the age condition, but not meet the indications. So I'll expand on this a little bit. So if someone injures their ankle, say they twisted their ankle. Okay, so that's trauma. Not severe trauma, but it's trauma.
Yep.
They might have an elevated heart rate because, it hurts when you twist your ankle. We've probably all twisted our ankle. We remember how much it hurts. And if you have that pain response, you get that sympathetic drive, your heart rate might go up. So now they've had trauma. They meet the heart rate condition. They might not meet any of the contraindications, but you're not suspecting hemorrhage.
Right.
And that's the important part when it comes to the medical directives, that you have to suspect that they have hemorrhage. So it's not just trauma, it's trauma with hemorrhage that you're suspecting.
Right.
So that's the one thing that I really want to point out here, because it can be, there's a lot of things in this medical directive. We just covered a lot of stuff here, but it's trauma with hemorrhage, meet the indications, don't forget about the primary and basics, and don't delay treatment to hospital.
That's awesome. Thank you so much. And as these new directives, including this one, when they roll out, it can take a while to get really comfortable with these. And I think that's where you, as medics, when there's just the two of us there, and for the majority of the time that's it, we got to say, like, there's nothing wrong with saying, what do you think, TXA? Or I don't know, like it doesn't look good, like, or maybe, I don't know, maybe I'll just hold up. I don't think this, with any new drug, it's going to take time to get a little bit comfortable with that. And, is it going to be perfect? No. But I think the way you summed it up, they have trauma. You think they're bleeding internally or it's external that we can't get under control. Go ahead and drop the TXA on board when you have everything else taken care of.
Yes, absolutely. And we know that that's a lot. As part of MCME, we created a little bit of a flow chart just to show you all the moving pieces that can happen in a patient who you're looking after who has trauma. And so we listed a flow chart. We're going to throw that up on the show notes as well. Okay. It just sort of takes you through some considerations of timing and things to treat for the traumatic patient. So take a peek at the show notes.
And that's awesome because that'll help fit all those pieces together. And of course, they don't have to occur like sequentially. A lot of the times they're gonna happen as they happen. And sometimes that's hard, but I mean, you got 10 different things going on at once. And but I think, we do our ABCs, get that under control while somebody else is doing this, while somebody else is doing that. A lot of it, we'll still get to that point. It's nice to occur sequentially if you have the hands, but sometimes it just doesn't happen that way.
Yeah, so keep that in mind when you look at that little box from MCME, is that things are written into nice little discrete boxes, but the world is gray. It doesn't always fit into those nice little boxes. And this is where you get to use your clinical acumen and decide what's best at the time. Awesome. Yep. So I guess the one thing I just want to summarize is this is fantastic. So TXA, we have a new tool in our tool belt. So this ALS PCS 5.4 just adds so many new tools to our pre-hospital care practice. We've got our supraglottic suctioning.
Yep.
We've got our lateral patella reduction. We've got TXA.
Yep.
And now we've got something that's now explicitly written into the ALS PCS that we've actually used in our SWORBHP region for a little bit. So we're talking about the tachydysrhythmia medical directive for PCPs, and that's what we're going to chat about next.
Awesome. Well, Lauren, as you've alluded to, we're going to be talking about, and we already utilized, the primary care folks out there already utilized the modified Valsalva in SWORBHP and have been for a long time. But let's chat about a few things that have come up during the MCME this year and that new change which involves the treat and discharge for tachydysrhythmias for PCPs.
Yep, awesome. That's a really great plan. And just for those that are listening, check out the show notes because we're going to link the references and the procedure itself, all of those things, because we're not going to touch on it just for the sake of time and because that's not new material for you. You've already learned that before. But Dwayne, we're going to talk about some special populations.
Okay.
So patients that don't have any lower limbs or the pregnant patients. So Dwayne, can you tell us about this?
Yeah, so absolutely. So, it's a contraindication for the modified Valsalva for the treat and discharge. So, and we start thinking about the rhythms that are involved here, and a couple contraindications are like sinus tachycardia, atrial fibrillation, atrial flutter, and that's okay. We talked about that and people know the reasons behind that. We talked about that during the research. But the pregnant patient, so just because they're pregnant, it doesn't negate treating the SVT or the PSVT.
Right.
But what it does, we can't do the treat and discharge with a pregnant patient because there's a lot that could be going on, and all pregnant patients, especially after performing this, they really should be going and be assessed, but we can still perform the modified Valsalva on them. So
Great summary, Dwayne. So pregnant patient, you can still do the modified Valsalva, but you can't treat and discharge that patient even if they meet all the other criteria.
Yeah.
Now there's another unique population we're going to talk about. So lower leg amputations. So do you take it away? Tell us about that.
So I mean, even though if they're amputated, there's still blood volume in there, and it may change the way we kind of lift the patients up. We're going to lower the head still, and we're going to maybe lift them up, but there's still blood remaining in there, and we want the goal behind that. And we talked about this, is that you want that blood to go back. And even though it's not like full length limbs, because they may be amputated at the knee or up high, the blood return will still happen. And that's where we maintain blood pressure and perfusion. And we want to increase that preload. Even though it thinks like there's just maybe this halfway, there's not a lot there, there's still volume there. And it's returning to the heart, and that's the main thing.
Awesome. And then the last subgroup of patients that we're going to touch on, and then we've answered some questions sort of Ask Mac, during MCME, etc. in the past, are patients who have the tachydysrhythmia SVT and chest pain.
Okay.
So Dwayne, can you tell us about this patient, modified Valsalva, and maybe a little bit more?
Yeah, so chest pain's not a contraindication to perform the modified Valsalva if they're an SVT or PSVT. And I mean, it's okay to do that. They may be having the chest pain because of the SVT or PSVT. They're generally two different etiologies, but that heart will kind of get ischemic. But do you want to stretch that out a bit, go a little further, just so I don't want to lose people here?
Sure, of course. So essentially what it comes down to is, do you think that the chest pain is because of the heart rate being so fast? So if you think the chest pain is because the heart rate is going so fast, absolutely go ahead and try to correct that with your maneuver.
Okay.
If you think that maybe some cardiac ischemia has caused the SVT, then it's okay to withhold the procedure as well. Just make sure you document to let us know why you did what you did. The bottom line is chest pain is not a contraindication to going ahead with the modified Valsalva.
Now, what about aspirin, Lauren? That question has come up, and can the patient receive aspirin and still qualify for the modified Valsalva?
So the short answer is absolutely. So if you suspect cardiac ischemia, you can go ahead and give that ASA per the suspected cardiac ischemia medical directive and still qualify for the modified Valsalva. However, they do not meet the treat and discharge.
Right.
So once you start treating with medical directives outside of the treat and discharge medical directive, so let's say you do the tachydysphythia medical directive, you break the SVT, they're feeling much better, they meet all of the other indications to go ahead and treat and discharge, but you give them ASA for suspected cardiac ischemia. Well, now you've treated with 2 medical directives.
Yeah.
So you can't treat and discharge that person if they meet only the 1 medical directive because you've treated with the 2nd medical directive.
Okay. Yeah, perfect. And I think that's where they can still, you still treat the patient. That's paramount, but we're not going to go down the treat and discharge path. So with that, is there anything else you want to kind of highlight regarding this topic or add to it?
So why don't we do a quick review of the consideration for the treat and discharge, since this is new for the PCP group. And I'll keep this high level. So 1, the patient must be between 18 and 64 years old.
Okay.
So not the super young and not the super old, because there's maybe something else going on that's caused that to happen, and we want them then to come to the hospital for further assessment. 2, the patient must have a prior history of SVT. 3, the patient must have only had this 1 single episode in the past 24 hours.
Okay.
4, the patient may be discharged, if they return to normal sinus rhythm, either spontaneously or with a Valsalva maneuver, or for ACP scope if you gave adenosine. So if you gave adenosine but they meet other conditions, ACP scope, they can still be discharged. Remember, they have to be asymptomatic in order to be discharged. The 5th part is a complete set of vital signs within the expected ranges. So for that, specifically the heart rate is less than 100. And the patient remains in that normal sinus rhythm for at least 15 minutes following the conversion. The 6th, almost there, the SVT
that's a lot.
Yes. Yeah. The SVT may not be due to alcohol or substance use or withdrawal. And then the last point is the patient has no fever or preceding illness.
Okay. Now I've got a really silly question. We take about substance abuse. Like, does that include, like, if the person had a couple big cups of coffee, like caffeine, does that negate them from having the treat and discharge?
Not a silly question. Not a silly question. So the wording in the treat and discharge is abuse. So drinking a couple cups of coffee, that's okay. If you're taking like handfuls of caffeine pills, so you're abusing the caffeine, that's when they fit into that condition that they do not meet the treat and discharge.
Right.
So it's the abuse.
It's the abuse thing. Well, now I'm not an abuser because I'm good. At least I can know now because I drink more. Yes, I drink a lot more than a couple cups of coffee when I'm in a shift and that sort of thing. So at least I know I'm within the normal population with this stuff.
Yes.
So
you got it.
Yeah.
And really, the bottom line is, if you're ever unsure, then the safest thing to do is to bring them to hospital. And I'll just touch really quickly on, I talked about the aspirin, and then once you give them the aspirin, they no longer fit that treat and discharge. Do not let that dissuade you in giving that person aspirin, because we know about how beneficial aspirin could be in the setting of suspected cardiac ischemia. So don't withhold aspirin because you want to try to treat and discharge them. Just put that aside and think, what do I think is going on? Am I suspecting cardiac ischemia? And then treat per the medical directive. So don't let the fact that giving them aspirin will negate them being able to be discharged. Change your management.
And I think that's important, right? If they're having what they describe as chest pain or a cardiac ischemic equivalent because they're in that SVT, right? I think it's important to get that aspirin on board. I mean, there's, like you said, there's a school of thought, well, if I break the cycle and there's no pain, but I mean, the heart is going so fast for such a prolonged period of time, maybe there is something going on. And I think that's important. I mean, it's not a must, but if they're presenting, why not, right? Like you said, and I think that's okay, and that's safe, and that's, we have that duty to act, and we're doing that. Is there anything else we need to think about here, or do you think we're okay?
Well, I think that brings us to the end of our content for our PCP folks. For our ACPs, we have also added ketamine in the setting of analgesia. So we'll do a quick summary for our PCPs, and then after that quick summary, we will touch on the ACP scope content regarding ketamine. So PCPs, you're certainly welcome to listen to the ACP content if you're interested after the PCP summary we're about to go through. But if you want to drop off after that, you're also welcome to do that. So the PCP content summary, and then we're done for them, and then we'll cover the ACP content.
Perfect. So Lauren, that sounds like a really good idea. So let's give a quick rundown of what we've talked about over the day. Well, Lauren, that sounds like a great idea. So can you give us a quick rundown of what we've covered so far today?
Sure, I'll give a real quick one.
Okay.
So we covered 2 memos regarding the medical cardiac arrest medical directive.
Okay.
Then we covered 1 new treatment as part of the ALS PCS 5.3 that's already out there.
Yep.
And then we covered the new treatments as part of ALS PCS 5.3. So namely SGA port suctioning, TXA, the tachydysrhythmia medical directive, and then we will touch on the 4th, which is the ketamine for ACP scope after this.
Awesome. So for the audience out there, can you kind of give a quick review of those memos just so we're on the same page?
Absolutely. So the first one was regarding a patient that does not meet the TOR criteria. So what that means is this person is always going to be transported because they don't meet the TOR criteria. Mm-hmm. So the bottom line is essentially you don't have to stay on scene for that full 20 minutes of resuscitation. You may stay on scene for those up to those 20 minutes, but you don't have to stay on scene for those 20 minutes. We do recommend that you stay on scene for 4 analyses. Mm-hmm. When you do depart, list on a whole bunch of different factors. We're not going to relist that or get into that discussion right now, but check out the show notes for the memo as well as a couple other notes on this particular memo.
Yeah, and those memos, that's a lot to cover. But the bottom line is, with that, we don't have to stay on scene for the full 20 minutes if we know we're going to be definitely transporting that patient.
Perfect summary.
Okay.
Perfect summary.
Okay.
I'll touch on the second memo real quick.
Yep.
So this one was also about the medical cardiac arrest medical directive, but this was regarding patients who arrest for the first time en route. The companion document now explicitly gives direction on these patients to pull over when safe, use clinical judgment to decide whether to stay and perform resuscitation or proceed to hospital. So this will include 3 full analyses and then proceed or patch or provide 1 analysis and go.
Right. And then so with those memos, where can I as a medic, where can I find it, and should I want to re-look at it and just make sure I'm on board? And
that's a great question. And ingrain these into your brain because you listen to these podcasts with the webinars, which is great. But then day of, what are you going to do? You're going to pull out your phone and you're going to look in your references. Okay. So they are located on the SWORBHP webpage, but they are also under the app. So under the medical references section, you can look up things like the APGAR scorecard, pediatric CTAS, etc. You probably know that those are in there, but the memos are also in there too.
Okay.
And Dwayne, do you think you can wrap up Suboxone?
Sure. Yeah, there's a lot to cover here, but I'm going to try to keep it as brief as I can. So Suboxone, or the buprenorphine, is a new medication that all of us can give if we're authorized and certified, if the service chooses to go with it, to help with those folks that are withdrawing and they have those withdrawal symptoms, and it gets them on the road to recovery to help with their opioid use disorder. And patients, basically, they have to have had taken drugs, there's been an overdose, they've received naloxone, Narcan, and then that Narcan be administered by anyone. It doesn't have to be EMS. It could be administered by police, fire, public access, whatever, but they had to have had that there. They've had to have had, they took drugs, they've overdosed, they've had the Narcan, and now they're in that withdrawal state.
Another great summary.
Well, thank you.
And we've got one more little rundown to go through, which is the summary of the new medical directive content coming out for ALS PCS 5.4.
Okay.
So I'll break it down. So the first one we talked about was the rebrand of the endotracheal and tracheostomy suctioning and reinsertion medical directive. It's quite a mouthful.
It is. Yeah, it's a lot.
It's still a mouthful. So now it is the advanced airway and tracheostomy suctioning and reinsertion medical directive. Okay, So with that, PCP paramedics are now able to suction at the distal tip of the SGA.
Yep.
And ACPs can now suction deeper into the stomach.
Into the stomach.
Yes. Okay. Second new thing with ALS PCS 5.4 is the new traumatic hemorrhage medical directive. It introduces a new medication, tranexamic acid, TXA, can only be utilized when there is a traumatic injury with suspected hemorrhage. The hemorrhage can be internal or external, and the bleeding is not controlled. The vital signs of heart rate greater than or equal to 110 and or hypotension are in place to help target that population of patients who are experiencing shock due to hemorrhage, and for which case you want to stop the bleeding as soon as possible. This is another tool in your tool belt for that.
Okay.
Third change to the ALS PCS 5.4 is the new lateral patella dislocation medical directive for pre-hospital treatment of suspected lateral patella dislocation.
Okay.
So the key for this medical directive is that it is based on history.
Okay.
So you're thinking especially the mechanism.
Yep.
So no direct trauma, no external force, and your physical exam where you look at it and you think, yes, this is truly just the patella that's laterally dislocated in the wrong spot. That's what you're going to use to determine, along with the whole list of the medical directive, whether or not to apply this new procedural treatment.
Great.
Fourth thing, ketamine. We're going to talk about that for ACP Scope after.
Awesome. That's a lot. It was a lot. It was another full year. So for everyone out there, there you have it, folks. So again, we hope by doing these fireside chats that it clears things up. We're always happy to answer questions. So whether you call us directly, you email us, it doesn't matter. You can go on Ask Mac. We can all benefit from that. So thanks again to all the folks out there, and we hope you enjoyed this. And Lauren, thanks again for coming in and giving your medical expertise on this stuff, because it's always good, because it's good to hear from the physicians about this stuff.
Oh, it's my pleasure. And it's nice to be able to recap some of these pertinent points and questions and things that come up at MCMEs.
Absolutely.
We're able to put into these fireside chats, which is awesome, because then it brings up questions that somebody else has had that at least I'm sure 100 of other medics in our region have. Yep. And then we can just get that information out there. So.
That's awesome. And we have shortbread cookies today, so that's wonderful.
Today.
Perfect.
Yep, and my mouth is no longer frozen because I went to the dentist because of the sugar. But
you did great. That's okay. Well, thanks, everybody. Take care.
Bye, everybody.
Okay, Lauren. So we've been waiting for this for a while. I'm excited because I've been waiting for this to come in for pain. Ketamine for analgesia. I know that it's a very safe drug. It does work. And I think it's going to be good for the folks out there. I really think it is.
All right. Well, let's get into it then. So before we touch solely on ketamine, which we're all very excited about is coming up for the use of analgesia, I want to touch quickly on the condition change that are coming down for some of the other analgesia agents. So specifically, new for ALS PCS 5.4, ketorolac and fentanyl will no longer have the condition of normotension required. So now you can give both fentanyl and toradol to a patient who doesn't have that condition of normotension. So notably, morphine still does require normotension for its use, since it is more vasoactive.
Right. And and the ketamine itself, that kind of like parlays nice into that, because you don't have to be normotensive to get ketamine, because it doesn't really mess with a person's blood pressure the way morphine does.
Yes, exactly. Well, with that in mind, let's get right into the directive.
Alrighty. So the indication is still pain, right? It's still pain, 1 year of age and up. So it's still the same type of criteria. So 1 year of age and up, we can go ahead and give that ketamine.
That's right. And still has the condition of unaltered. Yes,
that's right. So with that, we start thinking about how do we sum this up? And we think about contraindications. And I know everybody has their own way of remembering things. We can read it right out of the medical directives. The way I remember it is that it's an allergy. That's the very first thing. And then I kind of go CCCP. So like cranial pain, chest pain, chronic pain, or pregnancy pain. That's the way I remember it. The way it's listed, I'm going to actually read it verbatim. Allergy or sensitivity to ketamine, treatment of headache, treatment of chronic pain, suspected ischemic chest pain, or active labor. So it marries into exactly with fentanyl and morphine, the contraindications. That's just the way I remember it at 3 a.m. So whatever works, I think, as long as it's accurate.
And what these mostly point to is treating acute pain in a safe manner. So for suspected ischemic chest pain, you want to treat their pain, yes, but you also want to make sure that you utilize the cardiac ischemia medical directive.
Right.
So that's when you use your aspirin, your nitro if they have chest pain, and then your morphine as part of the cardiac ischemia medical directive specifically.
Yeah, exactly, because the morphine's already in there. If they can have it, then might as well start piggybacking that in. And there's a mandatory patch point for the administration of ketamine for patients less than 18. That is a mandatory patch.
Yes, and important to note is that this is different from fentanyl and from morphine, where the age is less than 12.
Right.
So that is a big difference when it comes to some of the details of this new analgesic.
Right. And then we start thinking, let's kind of move on to like the dosing and the treatment table. So ketamine's dosed by weight, and we can either go intravenous or intranasal routes. Now, the dosing, if we're going the dosing is like 0.25 milligrams per kilo to a max of 10 milligrams, and that's IV for 1 to less than 18. And then if we're going intranasal, it's going to be 1 milligram per kilo to a max of 30. And then for the 18 and over, I like to say the adult dosing of that, it's still 0.25 milligrams per kilo IV, and it's still 1 milligram per kilo intranasal, but the max dosing changes to 20 milligrams for the IV and the 75 milligrams for the intranasal. And we're allowed 2 doses, and they have to be 15 minutes apart.
Excellent. Thanks for taking us through all those details there, Dwayne.
It gets a little foggy with 0.25 and then 1. So, yeah.
Yes, important to remember that. And then if you're ever unsure, just pull up that app.
Yep.
Pull up the directive, look at it, and just verify.
Right.
A quick note about estimation for patient weight. So you can use the most accurate recent weight, as long as it's recent, if known, or you can estimate via the formula 2 times the age plus 10 in kilos. A quick note about that is that this estimate is best for use prior to 12 years old or around adolescence, which makes sense because after adolescence, you're an adult size. Yeah. So you no longer estimate in that regard. You can actually sort of estimate the way you would if they were an adult, because now you're also, for the most part, using adult-sized dosing. Yes. Keep in mind following that treatment table.
And that's an awesome reminder. And then we start thinking about the clinical considerations for this drug. And there's 2 important things to cover. So morphine or fentanyl and ketamine must be sequential. We can't co-administer them. And that's the very first thing. As well as the dosing interval. So it can't be earlier than the most recent administered med. That's the second thing. So like say if you start with hypothetically fentanyl and you want to switch to morphine, before we give that first dose of morphine, we have to wait 5 minutes because that's the dosing interval for fentanyl. Then we go on to the 15-minute prescribed thing. And it'll make sense as we go through this.
Yes. And then what that does mean is you can give ketamine and an opiate medication. So you can give ketamine and fentanyl or ketamine and morphine. So not both. So you can't give 2 opiates at the same time.
Right.
There is one little asterisk about that, which we're going to get to. But let's pause on that. Okay. And we'll get to the dosing interval and this whole wording regarding not co-administered. Okay. So what it means is that, let's say you have to extricate a patient and you want a quick-acting agent. You might give them fentanyl first. Okay. So there might still be a fair amount of pain. You can now give ketamine, but you have to wait the dosing interval of fentanyl before you give the ketamine. So the dosing interval of fentanyl is 5 minutes. Yeah. So after you give that dose of fentanyl while you're extricating the patient, 5 minutes after that fentanyl, you can now give ketamine. No patches are required. You can co-administer. You just can't concurrently give them at the same time. Right. So after that 5 minutes, you can give your dose of ketamine. Yep. So let's say that you've done that. You've given your dose of ketamine. Now we're going to wait another 15 minutes. They're still in pain. Now you can decide, do I want to give them the second dose of ketamine or do I want to go back and give fentanyl? Right. So you can go back and forth as well. Again, only the same opiate agent. And you can give it at the same time with ketamine, but you have to wait the dosing interval before the first drug given.
Right. So that makes sense. I get it. And that's where we had a lot of discussion around that. And they're like, well, can we jump back and forth? I said, the goal is to be able to do that. Right. And I said, and that's coming. And that's why we're going to be talking about this. But I have a question. So what if we gave fentanyl, then ketamine, and we want to give morphine? Can we do that?
All right. So great question. So the short answer in the pre-hospital field, the answer is no. So
just no.
Just no. So you can't give fentanyl and morphine together unless you have an order from a BHP in the field.
Okay.
Now, there's probably something ringing around your minds regarding a memo that came out on offload. So there was a memo that was put out in 2021 for our ACPs in the SWORBHP region, which we'll link to the show notes as well. But basically it says, we know we live in a world of offload delay now, and there are patients that come in pain, and that you might want to give them a longer acting agent, so morphine, after you've initially administered fentanyl. Mm-hmm. So within the SWORBHP region, if you have a patient who is now on offload delay, so you're already in, the back hallway of the hospital, they're still in pain. If you started with fentanyl, you can now give them morphine per the medical directive, so up to those 4 doses. Yeah. In addition to the fentanyl you first gave.
Right.
But you have to be on offload delay.
Right. That memo still stands.
Correct.
Okay.
Correct.
And so essentially, if I want a third med, say if I started with, say I'm on scene, somebody's, their arm's crushed underneath a transport or something. So say if I start off with fentanyl, or say I start off with ketamine, I'm probably going to go to ketamine quite often, really, to tell you the truth, because I think it's going to work great. So say if I start off with fentanyl to get that quick acting analgesic on there, and it's not cutting the mustard, and then I wait 5 minutes, and then I go to ketamine, and say that's kind of working, and then I give another dose of ketamine, so I max out. Now I'm at the hospital. If I want to try something like morphine, I need to pick up the phone and do a base hospital patch to get the green light to do that.
Yes. So super important. I'm glad you pointed that out. So the memo came out 2021. All the medical directors got together and said, yes, in today's world, which did not involve ketamine, if you give fentanyl, you can now give morphine if you're on offload. Right. But we didn't have ketamine at that time. So as part of that memo, there's no discussion of ketamine or where that fits in. We kind of have to see where that goes once it comes to get used before we roll that into the medical directive. Right. So if you gave the ketamine, then you give the fentanyl, and now you're on offload and you want to give the morphine, that's a third drug, you got to call.
Want a third drug, make a phone call.
And we're happy to answer those calls. And if things change down the road, we might end up rolling ketamine into that. Okay. But we'll have to see where we go. We'll have to see what happens in the offload world, all of those things. But follow the memo, which doesn't include ketamine. Right. Third drug, make a call.
Make a phone call. Awesome. And I think another important pearl that when we discuss at our hands-on day is all those dosing considerations and the math that we're trying to do.
Yeah, there's a lot to unpack there. So we already talked about the fact that there's different dosing for intranasal versus IV route. And obviously it's weight-based, so there's some math involved in that. And then there's another component that goes along with intranasal dosing, which you touched on in your hands-on day, is this theory of dead space. So Dwayne, why don't you tell us a little bit about that?
So like when we think about, so let's kind of go with like a 1-year-old and start thinking about that. So 2 times their age plus 10. So say 12 kilograms, maybe I'll, can I talk about the intravenous stuff first before I roll into the intranasal? Okay. So we want to go 0.25 milligrams per kilo, and we're going to multiply that by 12. So that gives us 3 milligrams. So our current supply of ketamine is 500 milligrams in 10 milliliters. So for easy math and for safety and all that kind of stuff, we'll draw up 1 milliketamine, which is 50 milligrams in a 10 ml syringe, and then pull 9 mils of saline in. So effectively, every 1 milliliter has now been diluted to 5 milligrams per milliliter. And to get the 3 milligrams, we would give like 0.6 mils intravenous. We have to dilute it down going intravenous. Okay.
That's the math part.
That's the math part.
And the dosing part consideration for IV, which is different than IM.
Yeah. So the intranasal, so if we go there, it's 1 milligram per kilo. And this will be for, say, a 12 kilogram patient. So we're actually, I hate to use the term, we're mainlining it out of the bottle. We're not diluting. We're just pulling it straight up. No dilution. It's the full strength. So again, with the intranasal, we're not diluting it because that's too much fluid. Okay. So we think about giving the 12 milligrams. We know we have 50 milligrams per mil. Do your math. Make sure you have that all set up. And that works out to 0.24 milliliters. But what the message is for the time being is, because there's possibly a dead space in the intranasal atomizer, and sometimes these doses are so tiny, we add 0.1 mils to compensate for the dead space. So we drop an additional 0.1 milliliters of drug. So instead of being 0.24, it would be 0.34 on the 1 milliliter syringe.
That's right. And then we would know that the 0.24 mils or that dose of that 12 milligrams has been delivered.
Right.
With that extra 0.1 still stuck in the atomizer somewhere.
So with that, does anything change with naloxone or midazolam?
And that's a great question. So when it comes to naloxone, the dose is just so non-specific that you don't have to worry about the dead space. And when we first came out with the atomizer, we talked about there might be a dead space, but don't worry about it.
Okay.
When it comes to midazolam, follow your current practices. In the companion document, it talks about procedural and it talks about that dead space of 0.1 mils that are in there. So best practices would be to add it to that. Somewhat unlike naloxone, the dosing is a little bit less specific when it comes to midazolam for treating a seizure. Now that we're talking about analgesia, we want to be really careful with that. So this is for sure for ketamine. Add that 0.1 mils.
And you know, the funny thing is, for years, we haven't done it because it was found that, like you said, it's not that super. It's not that super prescriptive, and it's not going to make a lot of difference as far as getting that stuff on board, right? Like with the naloxone or even the midazolam. But it's interesting. I mean, it's back. So we add the 0.1. We all have to do that and kind of move through that. So
for analgesia for ketamine, don't forget that extra 0.1 mil per each dose of the ketamine. Is there anything else at all you want to add about ketamine?
Yeah, so I think it's going to be a positive move forward. I know some of the big questions, like, you know, we really focused in on the math, and there was also a lot of meaningful conversation with, you know, when should we be doing this? What drug should we use? And I think it's really kind of open-ended, and it's not so prescriptive. I mean, yes, there's like normal tension requirements, LOA requirements, but it's more go ahead, independently provide the care based on what we think is best at that particular snapshot in time. And I think the ketamine is going to be good. The math is always a concern, but we have those conversations about that. And just what I said, like, you know, have your math ready, especially when they're less than 18, because we have to make that phone call. That way that you can tell the docs, hey, this is what I want to do. This is what I want to give. So those were the big things.
And there's so much more to juggle now. So I would say out of this ALS PCS, 5.4 coming out, the theme, if there was one, because it seems like there's a whole bunch of things all added at once, are tools to your toolbox, because a lot of the things that were added in are new, but also sort of attached to something you already do in practice.
Right.
And say ketamine specifically. So you have so many options now. You've got Tylenol, you've got Advil, you've got ketorolac, you have morphine, you have fentanyl, you have ketamine. You can use some of those together. You can't use other ones together. There's multiple different conditions that are required for each of them. There's a lot to take in, which is great. You want to have all those tools because the same thing doesn't work for every patient.
Right.
It's all based on the unique circumstance of the patient, of the situation, of the transport time, of so many different things. So when it comes to that, you now have like a much more expanded toolbox for analgesia specifically, but also some of the other things we talked about today. Just make sure that with all your tools, you know how to use them. You know them intimately. So to help a little bit with some of that, because ketamine is new, we've added a link in our show notes to a table that we had during our MCME that talks about that morphine, fentanyl, and but there had to be this. We're almost at the end of this.
That's okay.
I'm having difficulty with words now. But we have a table that outlines like the duration, the onset, the side effects, etc. So you really want to know the drugs in order to help you decide which one you want.
Right.
You want to really know them well. And I do have to acknowledge, like when you have multiple tools, there is going to be an element of a bit of a pause. It's like when when you go to Costco and you have like one box of cornflakes or like one type of ketchup. You've got regular old Heinz ketchup. It's massive size, but there's one brand. Versus when you go to like another grocery store and you have 12 different types of ketchup. And you stand there for a second and you go, which one do I want with my French fries?
Right.
So now we have this much larger expanded box, and it might take a little bit more of a thought process. To treat each of our individual patients. Not that there's a long delay, but I just want to acknowledge that there is a little bit more of a cognitive burden, which again is wonderful because now you're able to treat different patient conditions, etc., to the best of your ability. But I did want to acknowledge that there is a little bit more to add to your practice, just the thought process that goes behind everything.
Right. And that's awesome because sometimes we just got to slow down. Like this isn't a life threat here. We'll slow down and take our time, do our math and think what's going to work best, and then start rolling with whatever we think is going to be the best for that patient, like you said. But just kind of think about it. We have lots of different options now, right?
All those tools.
Yeah.
All those tools in that tool belt.
Yeah.
So that brings us to the end of our fireside. See, there we go. The end of the day. To our fireside chat for today. We won't do a full summary because we kind of did a summary with the PCP group, but we'll just do a quick ACP scope summary regarding ketamine. So in brief, it's a new tool to add your tool belts. We already have this medication for another indication. The dosing and the route is now different for analgesia. You already know about the potential side effects, so we didn't cover that today. Because it's a smaller dose, you're less likely to have those side effects, but you might still have them. So just remember what they are and be ready to act on those as required. There is a mandatory patch point, but it is for less than 18, which is different than opiate medications. And you may co-administer ketamine with an opiate, but you must look at the dosing interval of the first given drug, and you can't have both morphine and fentanyl together with ketamine.
Right.
Any last comments before we wrap up today?
No, I think that's it. That was awesome. Thanks again for coming in and spending the time going over this. I know it means a lot to us out in the field, especially when there's just been so many additions over the last few years and so many changes. It's hard to keep all that in check, and it's important that we do these things because when these hard and fast dates come out, the expectation is, myself included, is that we can utilize this if we need to. But when you've learned it 4 months ago, 6 months ago, 8 months ago, in some cases 10 months, it's good to review it, go over the fine points, get into the weeds on some things, and that way when that date comes around, the switch goes on and we move from there.
Absolutely. So with that, guys, thank you so much for listening. Thanks for all you do. Really appreciate it.
Thanks guys.
Dwayne.
Okay, no problem. Thank you.
All right, take care, guys.
Yeah.